So we're going to have a really interesting discussion today, and I'm going to keep the discussion hopefully confined to around 20 minutes. This is going to be on the basal ganglia, on the temporal lobe. I've been going through the different lobes of the brain just to give you some idea of the different hemispheres, the different lobes, what they're responsible for. And so let me see here. We're going to go through the temporal lobe, okay? Okay, so just explain the temporal lobe, just a brief overview. Then we're going to go through the receptors and then the nerve fibers running through there. Okay, I'm all the way at. Okay, where I'm at here. Okay, I didn't want to sign up for it. Let me just try the new chat. Okay. Temporal lobe. All right, let's get into it. Okay. Now, the reason why this is important, patient or anyone presents with certain sets of moods or type of behaviors, you need to have a good sense of what parts do what. And so you can sort of narrow it down at least to the hemisphere or the region. If you understand the hemisphere or the region, if you understand the blood supply, the nerve supply, and the receptors on those nerve bundles, then I think you have a really good idea of the routes you'll need to take to deliver the medications to these particular targets. And so we need to know exactly when we give the medication, we need to know exactly the endpoint of exactly where it's going to target it and what it's going to do. Otherwise, we're just guessing, right? If you don't really know the target of your medications. So here, the temporal lobe is one of the four major lobes of the brain, located on each side of the head. On each side of the head. This is really written so you can really understand it, below the temples and behind the ears. It plays a crucial role in several key functions, primarily related to auditory processing, memory, language, emotional regulation. Broca's area is over here. Here's this language, in this emotional area here. Below is a clear and concise explanation of temporal lobe. Its anatomy, function, and significance. Okay. The anatomy of the temporal lobe. First, let me show you what it looks like. Temporal lobe. Here we are, right here. So here we are, right here. Remember, when we looked at the networking, we was looking at the inner surface of the brain. Let me see if they have another. Okay, like this. This is the inner surface of the brain, and this is the outer surface. Remember when we were looking here, we were looking at the nerve fibers come up here. So when we were looking at the inner surface of the brain here, that's when we were able to look at the mesocortical pathway that goes along here. We look at the mesolimbic pathway that goes along here. So in the inner surface of this brain, you can see that's where we have the networking. And this is the outer surface, like here on the outer surface of the brain here. That's what we have there. Okay, so this the frontal lobe right here. Okay, temporal lobe. The temporal lobe is situated beneath the lateral sulcus, the sylvian fissure. Okay, let me show you here. The sylvian fissure here. I think this is it right here, right? I think that's the sylvian fissure right there. Correct me if I'm wrong. Sylvian fissure. Yeah, I believe this is the sylvian fissure right here. Okay. Which separates it from the frontal and parietal lobes shown above. The frontal lobe which is here. Yeah, the frontal lobe here, and the parietal lobe, which is here. And I think this is the Sylvian fissure right there. It's the part where the tissue sort of envelops on itself. It's a lobule. Okay. It borders the occipital lobe at the back. It is divided into several key regions: the superior temporal gyrus, auditory processing, language. Okay. The medial and inferior temporal gyrus, visual processing, object recognition, and memory. Right. The medial temporal lobe includes structures like the hippocampus and the amygdala. I kind of thought that the hippocampus was set apart from the medial temporal lobe, but the medial temporal lobe includes structures like the hippocampus, and thus we reviewed the hippocampus primarily for memory, and then the amygdala, the emotional processing center here, and this is simply just a subnuclei within the temporal lobe. Okay. Auditory cortex, located in the superior temporal gyrus, processes sound information. Okay, Wernicke's area. All right. Typically with the left temporal lobe. Wernicke's, yeah, essential for language comprehension and speech production. Remember Wernicke's encephalopathy? Yeah, temporal lobe area. Okay. The temporal lobe is highly connected to other brain regions, such as the limbic system. Yeah, I can imagine for emotions and memory, and the frontal lobe for decision making and planning. Can you see how it makes sense? Can you see how all of these lobes, they specialize in processing specific types of information, right? It does it in this cortex, and then it integrates it back into these centers that sort of process things. Okay, hold on 1 second. Just gotta send this text real quick. Okay, so you have the specialized centers that are specialized in processing only like one type of information, like the visual cortex only does the visual cortex, right? The auditory is only that type of information. And then it integrates it into these areas right here. So here, the temporal lobe is highly connected to other brain regions, all right? Such as the limbic system. Of course, you're going to need to get emotions, right, and memory to your limbic system and frontal lobe decision-making and planning. Key functions, okay. Auditory processing, yep. Language comprehension, memory, visual processing, and object recognition. Hey, Doc, how's it going? You're not on the stage yet, but how you doing, Doc? Hold on a second. So I believe I can still hear you. Can you say something, Doc, so I can hear you? So I think, let me see here. Okay.
So I know I had a good time. That's what I'm saying.
Oh, okay. Okay. Great. Hey, Faith, thanks for joining me. What I'm doing is that every day at noon for the students and for my patients, I'm going through the science behind psychiatry and neuropsychiatry. And so here, this is on the temporal lobe. And so I'm going through how it works, and I'll go through how it functions, the blood supply, the nerve supply. And then I look at the receptors, and I use the AI because it puts everything. Oh, it's amazing. It's amazing. So yeah, hey, jump in. Let me know if you want to be on active on the stage, or you can just contribute, or you can just stay audio, whatever you're comfortable with. Okay.
So, how long gonna be this podcast?
I try to do these for the students around 20 minutes because they don't have enough time. So I try and keep it below 20 minutes for the students because they're not gonna watch it if it's like 45 minutes. So I try to get it in for 20 minutes.
Yeah, no problem. I'm free now. So
okay, thanks for showing up, Doc. Okay. So here, visual processing, emotional and social behavior, olfactory processing. Okay, so let me just go through some of these. And so it's important to understand the function of this frontal lobe because when the patients come in with these type of issues, like if remember not really listening to what you're saying or not really able to comprehend or process what you're saying, that's a real issue. In order for someone to really understand what you're saying, that information needs to be encoded into their hippocampus first. And then those bits of declarative information is sent more to the prefrontal cortex to be rendered into some type of reality. But the thing is that if the thing you're telling the person never gets encoded in their hippocampus and sent for processing, it never gets rendered into the reality that you're trying to make. So you have a reality, you're talking to somebody else and say, please, can you get that? You said over and over and over. It's not getting into their system. So when they come up with a reality, it's a complete reality that's void of any of the items that you were arguing about or you're angry about. And this represents dysfunction in the parts of the brain and necessarily not the person being uncooperative or oppositional or defiant or anything like that. It's real. This language is about information processing. And if you are you have more awareness when you process, let's say 100% is the most awareness you're going to have, sometimes people can only get like 10% of the information you're saying. And if you don't recognize that they don't have the capacity to put more information into their system, then I'm not sure how you're going to develop a reality that's stable enough for you to actually communicate, that's close enough for you to actually have a relationship and communicate. So here, auditory processing, the primary auditory cortex, right? Processes sound information, including pitch, volume, and tone, right? Pitch, volume, and tone. Recognizing a friend voice or identifying a song. Remember, what is that syndrome? I know I got a lot of students around, so I know you call this out if I say it wrong. Capgras syndrome or something like that. I think imposter syndrome, it was the someone wake up with the type of brain lesion. They believe that they don't recognize their loved one's voices or things like that. I'm not sure if it's the same one, but I recall that. Here, the primary auditory cortex is here in the temporal lobe. Language comprehension, Wernicke's area, right, is crucial for understanding spoken and written language. Here, damage to this area leads to Wernicke's aphasia, where individuals produce fluent but nonsensical speech and struggle to understand language. This symptom I never get right. When patients present to me with Wernicke's encephalopathy, it's hard for me to pick that up. It's hard for me to grasp it when I see it, and so I usually make errors first. I usually think it's something else, and when things don't work out, I have to go back and sort of review this and try to look for these type of aphasias. Yeah, but when a person speaks fluently and none of it makes any sense, if it's fluent speech and you can't comprehend any of it, we're talking about there. Here, memory, look, hippocampus, right? Medial temporal lobe, essential for forming and retrieving memories, particularly declarative meanings, objects, just the facts, not abstract concepts. Like you can't find love in memory. You find a chair in memory, right? A chair, your declarative meaning is a chair, not how you feel, your wishes or your ambitions. It's a chair, it's an object, something like that. Okay, so these cortex here consolidate memory. Okay, next we have visual processing and object recognition. Okay, I never get into these. Okay. Emotional and social behavior. Yeah. Here it is, the amygdala, located deep within the medial temporal lobe, regulates emotions, particularly fear and pleasure, and plays a role in emotional memory. And then olfactory processing. So here, I just wanted to go through a few. It seems like there's more information here, but left versus right. The temporal lobe exhibits functional lateralization. The left temporal lobe, dominant for language, right? Speech comprehension, verbal memory. I think that's one of the keys of aphasia for the left, right? And right temporal lobe involving nonverbal tasks such as visual memory, spatial processing, and music perception. Yeah, right. Yeah, very interesting. And let me know if you have any questions, or if you want to make any comments, just let me know and I'll be able to sort of update things from there. But let me know if you have any other questions. And Dr. Rahman, did you have any, would you like to be on here or just the sound?
It's okay. I mean, I'm in the room, so no problem.
Okay, I didn't know if you're the type of doctor that hides all the time.
Yeah. I can shut it off if I want. It's an option over here, you know.
Yeah, you have people who don't want to be seen. Okay, all that everything. Okay, but you're doing okay, no, Doc?
Yeah, I'm doing okay,
Yeah, and I know I just dropped this on you like 5 minutes ago, but any comments about the temporal lobe or anything like that? And what you say?
Yeah.
Okay, let me just introduce you. Me and Dr. Rahman work together. He's the medical doctor. I'm the psychiatrist, and we work as a team. And we provide very good care for our patients and our students, and education for our students. And so we're looking for ways to sort of improve our care and so we're going to focus on educating our patients, and families, and the students. And so me and Dr. Ron, we work together. We've been working together for a while. Hey, it's been a pleasure working with you, buddy.
Thank you. As long as you're with me, I'm fine with you.
Any thoughts about
a good team?
Yeah. Any thoughts about the temporal lobe and things like that?
Yeah, I know. I just had to know. What receptor is the prominent over this? Dopaminergic or serotonergic? What is the most common over there?
I think it's dopaminergic.
Okay.
But let me just see, because we're going to go over the receptor profile. Let me just try that now. What is the See, I'm trying to make it useful for the students at USMLE. So
yes, they have to familiar,
things that they will find useful. And so let me just review this real quick. So guys, remember, in the temporal lobe, we went through the hippocampus, we went through all the cortex, we went through all of these lobes. Remember, the same concept applies. Glutamate is the main excitatory neurotransmitter. It's present throughout all the tissues. GABA is the main inhibitory neurotransmitter. Those are the main activation, deactivation, things like that. And then you have things like norepinephrine, serotonin, acetylcholine, alpha adrenergic receptors. And I would say those are very significant receptors, but those are primarily localized within the area. They're not generally just well distributed throughout the body as glutamate and GABA. And so look here, when it comes to the temporal lobe, look, glutamate receptors. Right? Glutamate receptors, look, GABA receptors, right? And then here's our host of other receptors. Acetylcholine, look, attention, learning, and memory, right? The dopamine receptors. Remember, this amygdala and hippocampus, remember the dopamine, if we need to stabilize that mesocortical pathway, or if we need to stabilize that mesolimbic pathway, here are again, dopamine receptors in the frontal lobe also. Here we are again, serotonergic receptors. Cannabinoid receptors work here. I don't know too much about the cannabinoids. So any what do you, so Doc, here are basically the receptors on this profile. So whenever I have patients who exhibit just frank agitation, rage, aggression, combativeness, then I sort of also view these as like emotional, like seizure-like activity in the emotional areas of the brain, but not the motor. Do you see it like that? I sort of see it like that hyperactivity is more like prolonged, seizure activity. What are your thoughts about that, Doc?
No, I know. Most probably the dopaminergic, that's why you want to have, and his language and all those things, important part of this area, so emotional and there, all those things. So I think it's important, so to know, that area.
Well, I know you probably noticed this in my prescribing pattern that I started using dual mood stabilizer, Depakote and lithium.
Yes.
Extended release first thing in the morning. First thing in the morning, right? Have you noticed that?
Yes, I noticed that. Yes, both of you. Yeah.
Have you seen a change over the years? Because I think I started that maybe like 3 years ago or something like that. Have you seen the change in terms of the acuity?
Yeah, I always have a question, but anyway, now you told me, so now I think yes. I was thinking, sometimes in the number of medicine you give patients, we're going to take it or not. So I always had a question: one is better or multiple is better? So if the patient know that they need that, yeah, it's fine, But most of the patient, they don't know how many medicine has to take. So that is the problem. So polypharmacy sometimes gets really problematic.
Yeah, well, actually, I'm glad you got a chance to meet me and my team, because what we try to do when the patients come in very agitated or combative, we really try to get them under control right away.
Yes, right. Stabilization.
And then when they get up in the morning, if they agree to take the long-acting Depakote and lithium, then basically those are loading doses. And so I'm trying to really get to a therapeutic dose around day number 3, because I know I'm trying to dial down. I feel like I'm trying to dial down that activity in their temporal lobe, because I don't want them to get up agitated, combative. Yes. And in a rage, because that's going to continue the same cycle that they came in the hospital for, So, and we do that sort of religiously in the morning, so they get there and get it started right away. Do you see a difference on the patients? Like,
yes.
They be nice and toasty.
Yes. But we have a problem with the young patient. But young patient is the problem. They refuse, they don't want to take it. Then you get the problem. So.
Yeah. It's a challenge. It's a challenge. So let me see here. I'm gonna see about the blood supply. So let me see about let me go through this again. For glutamate receptors, I still use Namenda, because Namenda is very effective for decreasing glutamate activity. So if I have someone with a history of, typically maybe a bipolar mixed disorder, combative, agitated, aggressive, I'll always see about adding Namenda if I can't get the agitation under control with the mood stabilizers and the antipsychotic medications. And so, and I use basically Depakote and lithium to address the glutamate receptors. Depakote and lithium will upregulate the GABA receptors. Okay, and our benzodiazepines can be used to treat GABA, to target activating the GABA receptors. So I think it's more of the A site of the GABA receptors where the benzodiazepines bind and they activate GABA, and GABA exerts that inhibitory tone, turning off all the activity in that in the temporal lobe. And here we also have the acetylcholine receptors. The acetylcholine receptors are very effective at helping increasing the person's sensorium. Improving attention, concentration, things like that. So the patients with the very severe schizophrenia, schizoaffective disorder, bipolar disorders, I started putting on Aricept. So that I can activate that acetylcholine system, and that helps with the cognitive impairment. That helps decrease the agitation a lot, Doc. Aricept, yeah. And they have a new antipsychotic out that's based upon the same, targeting the acetylcholinesterase receptors only in the CNS, not in the periphery.
Okay.
So the new antipsychotic is a branded medication, but basically works the same way as acetylcholine, as Aricept. Okay. Now we also have our dopamine receptors, the dopamine 1 through 5 receptors. Now remember, the typical antipsychotics primarily focus on the D2 receptor. So in these cases with temporal lobe, let's say epilepsy or agitation and things like that, if you give a typical antipsychotic, remember, it's going to help stabilize those pathways. It'll bring down the anxiety, but it doesn't target any of the other receptors here inside of the temporal lobe. So we have two strategies. When the patients come in initially, we want to deal with the risk, the danger, and that's when we'll put them on a typical antipsychotic. But then once they stabilize, we want to transition them over to an atypical antipsychotic. And the reason why is because the atypical antipsychotic targets acetylcholine, dopamine, serotonin, and norepinephrine. So with a atypical antipsychotic, you're going to get a broader range of receptors that are targeting things. Okay, so for the dopamine receptors, you can use atypical antipsychotics for these disorders as temporal lobe. Here, serotonergic receptors, right? So we're talking about antidepressants, SSRIs. Right? Remember the selective serotonin reuptake inhibitors, that can be very effective in treating and stabilizing it. Cannabinoid receptors, these C1 receptors are metatropic receptors. Remember, these are the ones that result in gene expression. Remember, you have the gates that turn on and off due to charges and things like that. And then you also have the G proteins that actually code for products to be produced by the cell body, and then those products are then exported out the cell. So this is the cannabinoids here, neuropeptides like opioid receptors, hormone receptors, olfactory receptors. So definitely for glutamate and GABA, you can use the mood stabilizer Depakote and lithium. For acetyl, if they're diminished and so on, very inattentive, unable to unable to focus, you can target the acetylcholine system with Aricept. And with the other receptors, after you stabilize them on the typical medications, then you can switch to atypical medications to get the broader receptor profile to target here. So any thoughts about this, Doc? And then I'm at 29 minutes, so I'm gonna have to go through the blood supply real quick because I wanted to keep it down. Let me just go through the blood supply real quick.
Temporal blood supply.
Okay, can you explain the blood supply? Can you explain the blood supply in the temporal lobe? So I'm not going through all this. Got 10 minutes over. So let's see here. Let me just go through the main supply. It's medial temporal artery. Right here, remember this circle Willis? Medial. Okay, let me get to this. Okay. Middle cerebral. Okay, here's the anterior cerebral artery, coronal. Cerebral, yeah. So here, middle cerebral. This doesn't show. Here's the circle of Willis here. So this middle cerebral artery here. This doesn't really show it. That's not a good design to show what we're looking at. Okay, so it's supplied by the middle cerebral artery. Okay, you can read this later. The posterior cerebral artery. Okay. The MCA arises from the internal carotid artery and is the primary supplier to the lateral and superior portions of the temporal lobe. So it's the middle cerebral artery. Okay. And here, the posterior cerebral artery. The PCA arises from the basilar artery. Okay, and supplies the medial and inferior portions of the temporal lobe. Okay, great. And you can read the other. I don't want to go in too deep into that. I don't think it's going to be on your examinations. So Doc, did you have any other questions before I go ahead and take some questions from the audience at all?
Go on. So I'm still, in the process. So if somebody had a stroke in the temporal area, so their language will be affected if it's in the left, and also the thinking. That is, their mind. What do you call? What is mostly affected? Their memory or their thought processing will be affected, isn't it? If there's a stroke in the temporal lobe.
Yeah, when I see these type of issues, the communication is disrupted.
Yeah.
But then they seem to behave as if they're unaware that you don't understand what they're saying, and they go on talking fluently, and you don't understand what they're saying and stuff. And so sometimes it's been hard for me to sort of pick that up. But in these cases, and so in terms of that's what I would do as a psychiatrist. So from your perspective, what are your thoughts? What do you do from your perspective when these patients come in?
Their thought process will be like a concrete. It's just like not a not a variation in speech or WhatsApp type of thing. They talk like different things, different time, different aspects, like all gibberish, WhatsApp type of things. Or is just a concrete thinking or speech?
I'm sorry, repeat that again. I didn't get the last part.
If they had a stroke in temporal lobe, so what will be their language? It'll be like they'll be having like a word salad type of thing, or they're just talking stuff. Or
Would you also think of that? I sort of think of that more as a disorganized thought process. And so they present with more of a disorganized thought process when they come in with these temporal lobe issues. Yeah.
Especially strokes,
Sounds good. Okay, I'm at 33 minutes. I was only supposed to 2. Your camera is upside down, Dr. Rahman. Okay, great. All right, so I'm gonna go ahead and sign off for today. Guys, if you have any comments, then you can just put them down in the comment section. I'll try and get back to them a little bit later, but I didn't want to go for too far since they're going to start watching my lectures so I go too long. Okay, so thanks, Rahman. Thank you so much for joining the show. I appreciate it. Then we'll talk with everybody.
What's the next topic tomorrow?
See, today, right after this, I'm doing another podcast on, check this out. So I'm... I'm about to start stuff. All right.
Okay.
No, I'm doing a series.
Keep me updated. You just text me hey, come and join.
You may want to join it. So I'm doing a series on narcissism as a network.
Oh yeah, that I need to. Yes.
So narcissism is not an individual. That's just the node.
Okay.
And that network is getting close to you. So the subject is on narcissistic Black family cults. And I'm using the Jacksons as the first example of a narcissistic family cult. And I'm going to do several series on each one of members, like Michael Jackson and things like that. Like, I think your camera just went off. Michael Jackson, I guess that's the end of the show. Okay, until then, folks, I'll see you guys later. You have a nice day. Today, we're going to have our discussion on acetylcholine. And how very important the acetylcholine receptor and the acetylcholine networks are. They're very important. And in fact, as I mature and grow as a clinician, I'm starting to understand how important the role acetylcholine plays in how the symptoms are manifested, right? So acetylcholine is important for a lot of very important things in the body, such as things like memory, things like arousal, things like that. And we'll do a deep dive into the acetylcholine muscarinic network, and then hopefully I can give you an idea of how this network operates and how useful it'll be for you as a clinician. So let's see. Okay, here, so I'm on the free version of Grok here. You can use any search engine. Here, explain the acetylcholine muscarinic network. Okay. The acetylcholine muscarinic network refers to the system of neural and physiological processes involving acetylcholine, which is the neurotransmitter, and its action on the muscarinic acetylcholinergic receptors. Look at this. Muscarinic, right? Acetylcholinergic, right? Receptors, right? Muscarinic acetylcholinergic receptors, right? This network plays a critical role in the central nervous system, the peripheral nervous system, and various psychological functioning, right? And see, this is why we want to know more about the acetylcholine for its impact on the central nervous system, and also look, various psychological functioning, well-being, memory, attention and concentration, things like that. Those symptoms sort of give you a reflection of how well the central nervous system is operating, but it doesn't show you actually where the dysfunction is coming from. So when we talk about the CNS, we talk about the specific targets in the tissue. And we talk about the various psychological function, meaning that the symptoms you have, the diminishing snoring, lack of awareness of the environment, things like that. Those are the psychological issues it creates. Below is a comprehensive explanation of acetylcholine muscarinic networks, components, mechanisms, functions, and significance. Before I get to this, let me tell you why this is so important. Let me look. Okay, here. Explain. So, Aricept is a medication that targets acetylcholine. It inhibits acetylcholinesterase, and that's the enzyme that breaks down acetylcholine. So that's the strategy, all right? Now, why would I use Aricept? Let me give you an example. Whenever you have patients with head injuries, okay? You can get damage from multiple locations with the head injury, right? And this damage can result in just diminishing snoring, lack of awareness of environment, fatigue, tired, there's difficulty thinking, and that's a result of the damage. And so that diminishing snoring is likely attributed to deficits in acetylcholine in certain parts of the brain, right? So somehow in the diffuse traumatic brain injury and other head injuries and things like that, the inflammation and things can lead to changes that result in a diminished amount of acetylcholine in certain very important parts of the nervous system. And so, of course, we're going to need to shut off the enzyme that degrades acetylcholine. Once we shut down the enzyme that degrades acetylcholine, then the amount of acetylcholine builds up in the synaptic cleft, and hopefully it's enough to start improving transmission along the acetylcholine muscarinic network. If we get more hyperactivity in that network, then we get more arousal, we get better attention, we get better concentration, we get improved memory. So in patients with diffuse traumatic brain injuries, you want to look at the acetylcholine muscarinic network, and if they're having difficulty with attention and concentration, impulse control, things like that, you may want to consider Aricept to increase that acetylcholine muscarinic network activity. But let me just show you a few studies that support the use of Aricept and acetylcholinesterase inhibitors in diffuse traumatic brain injuries and other type of brain disorders, including Alzheimer's dementia, right? So Aricept is also known as donepezil, is a medication primarily approved for treating symptoms of Alzheimer's disease. where it works as a cholinesterase inhibitor to increase levels of acetylcholine, a neurotransmitter involved in memory, learning, and other cognitive function, right? In the context of traumatic brain injury, Aricept is sometimes used off-label to address persistent cognitive defects, such as sometimes used. I think it should be used more. And it's not really, Aricept is not really associated with a lot of different side effects, such as memory, attention problems, reduced processing speed, and this can occur due to damage to the cholinergic fibers in the brain. Damage to the cholinergic fibers, right? That damage could have been caused directly by inflammation, right? Or direct damage, such as a traumatic brain injury, right? This off-label application aims to enhance neurocognitive recovery by boosting acetylcholine availability, right? Potentially improving brain metabolism and supporting functions like arousal, motivation, and REM sleep, right? On the studies on Aricept and TBI, including case reports, open label trials, and small randomized controlled trials have shown mixed but generally promising results. I've had a lot of, but you have to use it specifically on those patients, but I've had a lot of results for this. For instance, it's been associated with improvement in short-term memory, sustained attention, and overall cognitive function in patients with a chronic TBI. That's true. That's true. Here, there's a PubMed citation. One pilot study found enhancements in visual memory after 4 weeks of treatment. Another small scale study reported significant gains in processing speed, learning, and attention. So this is in the case of a diffuse traumatic brain, of a traumatic brain injury. Let me see. Okay, I'm saying explain Aricept, the use in Alzheimer's dementia, because remember with Alzheimer's dementia, you get loss of those cholinergic neurons, right? And so we want to use donepezil or Aricept to shut off that cholinesterase inhibitor and stop the degradation of acetylcholine, so we can increase the constant titer in the synaptic cleft and therefore increase the network activity. So here in Alzheimer's dementia, let me just go through this mechanism again. Aricept is a cholinesterase inhibitor widely used to manage symptoms of Alzheimer's dementia, a progressive neurodegenerative disorder characterized by cognitive decline, memory loss, and impaired daily function. So the symptoms of Aricept really focus on those memory problems, and then you start to see them over time have a diminished awareness or diminished alertness, things like that. So this is why we use Aricept in this case. And just look at the what we use for. Again, inhibits acetylcholinesterase, the enzyme that breaks down acetylcholine in the synaptic cleft, thereby enhancing cholinergic transmission in the brain. It must have been listening to me because it said the same thing I said. This temporarily improves communication between neurons, right? Helping to alleviate cognitive symptoms of Alzheimer's, particularly in the mild to moderate stage. You see this? You got it? Acetylcholinesterase muscarinic network hypoactivity leads to the symptoms consistent with Alzheimer's dementia, right? Patients with schizophrenia typically may, or substance abuse issues may have the diminished cognitive awareness and things like that, difficulty thinking, difficulty with their memory. Yeah. So even in the case of schizophrenia and bipolar disorder, you have to start looking at those acetylcholine networks to see what's happening there. And so amenda can go a long way in these cases, okay? And we want to use these, improve cognitive functioning, right? Look, memory again, look, attention again, concentration again, and what? Visual spatial. I'm sure your visual spatial will improve if your memory, attention, and concentration improves, right? Okay. Slow symptom progressions. While not cure, it can delay worsening cognitive and function decline, although patients maintain independence longer. Enhance daily function. Patients may show better performance in activities of daily living, such as managing tasks. So, diffuse traumatic brain injuries damage the acetylcholinesterase inhibitor, the cholinesterase network, boom, hypoactivity. Alzheimer's disease, same process, mechanism different. traumatic brain injury due to trauma, Alzheimer's due to the buildup of those like inclusion bodies, right? And they kill the cell. Let me see. Let me look at, we're going to go to a different neurotransmitter system. Let's say Parkinson's dementia is primarily dopamine in the basal ganglia. But let me see the impact, this relationship between that acetylcholinesterase muscarinic network and Alzheimer's in Parkinson's dementia. Okay, explain the use in Parkinson's dementia. Okay. Because remember, the movement disorders, the sort of the mass spaces, the stiffness and things like that, the shuffling gait and the postural instability and things like that. But I'm sure the cognitive functioning is diminished also. So even in patients with Parkinson's dementia, where the disease process involves a different neurotransmitter, particularly dopamine, I think we still have to consider acetylcholine, because you still have the diminished cognitive issues seen in Parkinson's dementia. And how are you going to address those? So here, explain Aricept use in Parkinson's dementia. Aricept is a cholinesterase inhibitor. We got that. But use off-label in cognitive symptoms in dementia, a condition where individuals with Parkinson's disease develop dementia characterized by memory impairment, executive dysfunction, and difficulties with attention and visual spatial. Right, mechanism still works by inhibiting cholinesterase inhibitors. The utility still cognitive benefits. Okay, functional behavior and symptom stabilization. Okay. So of course it's off label, but if your patient comes in with those noticeable cognitive deficits, you're still going to have to do something to help them with attention and concentration. And this is one of the reasons why I use it. Let me see. Let's see, what else can I look for this? I think that's it. So now you would see the indications why we would want to use target this acetylcholine muscarinic network. Now let's look at the actual network and let's see how it functions. Okay. So here, overview of acetylcholine and muscarinic receptors. Okay, so they take these two at the same time. So they take the acetylcholine, they address acetylcholine and muscarinic receptors at the same time. Okay. Acetylcholine is a neurotransmitter widely used in both the central nervous system and peripheral nervous system. All right. It interacts with two main types of receptors. Okay. The nicotinic receptors and the muscarinic receptors. These are ionotropic, right? Metabotropic, right? These are ligand ion channels, right? These are G proteins. And and then look, slower mediated modulatory effect. Now, you see that strategy also where each fiber system, whether or not it was the mesocortical pathway, or was a mesolimbic pathway, or remember the pathways in the basal ganglia, it was always a combination of receptors that operate ligand gate ion channels, and then another population of receptors that actually modulate the G protein receptors, right? And here we see the same pattern on the acetylcholine muscarinic sort of network. You see the receptors that target the gates, and then the receptors that target the G proteins. Here's why that's important. The gates are responsible for their signal transduction, propagation of the actual potential, right? And the metabotropic, that's the ionotropic, right? That's the fast acting to get a response right away. And it also sets off that actual potential to send that signal down to the terminal, the other end of that neuron, to tell them to release the gates, release everything that's been stored up. So that's one way that receptor gets its products exited out of the cell by the signals that goes along for the action potentials. The other group of receptors, the muscarinic receptors, metabotropic receptors, are the G proteins. Now, remember, the G proteins is the signal transduction cascade when the molecule target attaches to the ligand on the G proteins, which are usually huge 7-unit phospholipid membrane layer spanning molecules that convert their 3D configuration, which results in the 2 subunits breaking off and they become active and start creating things, right? So this muscarinic receptor is eventually going to send a signal to the cell body to create a product that is going to eventually export. And to create that product, it takes a while. It takes some time to create that product. The action potential is long gone by the time the product actually exits the cell. And it can produce, so these G proteins can produce products that secrete things from the cell, in rapid filler, or activate other type of channels and receptors. This network has those 2 type of properties: the collections of gates and then the collections of products that we'd like to create. The muscarinic network specifically involves the muscarinic receptors, which are named after their sensitivity to muscarine, a product derived from certain mushrooms. Okay, these receptors are found in various tissues, including the heart, brain, smooth muscle glands, and autonomic ganglia. Great. Number 2, the types of muscarinic receptors. Okay, mechanism of the muscarinic network. Let me see. Function of the muscarinic network. Neuroanatomy. Okay, I don't think I'm gonna go through the neuroanatomy. The pharmacological relevance. I don't think I'll go through that. Modulation. The muscarinic network is tightly regulated. Acetylcholinesterase breaks down acetylcholine in the synaptic cleft, terminating the signal. Feedback mechanisms from the muscarinic 2 and 4 receptors on the presynaptic cells act as autoreceptors, inhibiting acetylcholine release to prevent overstimulation. Wow. Okay. And then crosstalk. Muscarinic receptors interact with other neurotransmitter systems to fine-tune neuronal activity. That makes sense, right? So in order for regulation, if we want to increase the activity of the muscarinic network, then we release acetylcholinesterase. It breaks down acetylcholine in the synaptic cleft, right? No, it causes. Let me move over here. I'm getting confused there. So let me go back up here. Okay. So let's look at the types of muscarinic receptors. There are 5 types of muscarinic receptors, 1 through 5, each with distinct distribution, signal mechanisms, and functions. They are classified based on their coupling to specific G proteins. Wow, okay. So 2 types. And then it's always like that. Remember, like the types of dopamine receptors and everything. And then remember the type of like the serotonin receptors and things like that. And inside that family of receptors, there are some that activate things, and then there's those that deactivate things. There's another pattern you'll see here with every neurotransmitter is that they're divided into activators, modulators, or inhibitors, and you see the same thing here. And sometimes all the details like M1, 2, 3, 4, it can be overbearing, but to remember, but just understand that structure is there. The ones that activate the receptors and and they're all clustered together on the network. 1, 3, 5 GQ coupled. These receptors activate this G protein pathway. It increases intracellular calcium and it activates protein kinase C. They are generally excitatory, right? Now, M2, 4 are these couple receptors. The receptors inhibit adenylate cyclase, right? Reducing cyclic AMP levels and can modulate ion channels, particularly calcium channels. They are inhibitory. So the 2 type of muscarinic receptors. Okay, so let's see where they're found. Okay, so there are 2 of these. Let me just see where these are found first. 2 and 4. 2 and 4 found in the heart, the slow heart rate, slowing the heart rate, I can imagine. CNS, small muscles, highly expressed in the autonomic system. And 4, okay, so it's found in the heart, and 4, primarily in the CNS, involved in modulating dopamine release and motor control. So, wow, so this is where the muscarinic network starts to influence this dopamine network, remember? So I think that's, we see some of those improvements too. Remember in some of those hypodopaminergic states, like Parkinson's, dementia, we also see them get better when we give them Aricept. And I guess here the Aricept results in release of more dopamine. I guess the Aricept indirectly can improve the dopamine release. I guess that's the mechanism. It's very interesting to know that. Okay, here, 1, 3, and 5, they activate the pathway and increase intracellular calcium, and this activates protein type C. So 1, 3, and 5, predominantly in the CMS. Okay, yeah, look, the cortex, hippocampus, and striatum, involved in cognitive functions such as memory and learning. Okay, so this is where the muscarinic activates it here. Very interesting. Found in the heart. Okay, we did that one. 3, present in smooth muscles in the GI tract, brachial tissue, glands, and the CNS is involved in smooth muscle contraction in glandular tissue. Remember, one of the side effects of Aricept is drooling, running, all things running, drooly mouth. You see salivary glands, runny nose, and things like that. And this is one of the side effects because it hits these M3 GI receptors involved in smooth muscle contraction. Okay, then we have M5. It's less abundant. It's found in the CNS, substantia nigra. Hey, an abundant vascular endothelium plays a role in dopamine regulation and vasodilation. I guess this M5 is very important, particularly substantia nigra. This is where Parkinson's dementia, this is where the pathology is at. And so when using Aricept and that for the cognitive benefits, I can see this is why. It's through the M5 receptor. Okay, now let me see. Let's see. I don't want to go too far into some of this. Okay, I think the mechanism is okay. Okay, mechanism, yeah. Okay, the muscarinic network operates through the interactions of acetylcholine. Okay, great. All right, or the acetylcholine muscarinic network triggering intracellular signaling cascades. Okay, great. So these 1 through 5, okay, they activate the protein. Yep, and 2, 4, okay, they inhibit it. Okay, we got that. Okay, let me see. Functions of muscarinic network. The functions of the muscarinic network modulates a wide range of physiological processes in the CNS, cognitive and memory. Yep, motor control, receptors in the basal ganglia. Okay. Yeah, so muscarinic, wow. So yeah, so they're located throughout the basal ganglia. I never really read too much about the acetylcholine receptors located in the basal ganglia, but I guess in motor control, this is very helpful. Influencing movement and coordination relevant to Parkinson's disease, right? Sleep and arousal, muscarinic receptors regulate sleep, wakefulness, and REM sleep via cholinergic neurons in the brainstem and forebrain. Okay, then we have the peripheral nervous system. Okay, it mediate parasympathetic effects. Okay, slow heart rate by inhibiting pacemaker cells and promote contraction of GI motility. Okay, I think that's it. I think that's half for now. Okay, and then let me see if I have any questions. Okay, and we're at 25 minutes now. I didn't want to go too far into this. Let's see. Let me have a question here. Hey, T-Jam, thanks for the question, buddy. Did Muhammad Ali suffer from a TBI? I think so. A diffuse traumatic brain injury, multiple ones. Was he on Aricept after his injury? I would think so. You know, Aricept's been around for several decades, and so I think they would have definitely had him on there. Okay, guys, I hope this is helpful for you guys. And so now when let's say, hey, iHash guy. Thanks, iHash, for the question, buddy. Why do Alzheimer's patients often have a disrupted acetylcholine system? You know, because it has a predilection, the pathology has a predilection for cholinergic neurons. And so you get the death of cholinergic neurons in Alzheimer's dementia. And that's when you get all the cognitive problems that we just read about, right? Okay, so it's at 26 minutes. I'm gonna go ahead and call it for today. If you have any other questions for me, in the chat for me, I'll get to them if I can. So for other week, read out, you guys take care of yourself. Yeah. Today, we're going to go over serotonin receptors. Serotonin is very important. Very important. You know, every time I think of the new neurotransmitters, it seems like when they're in excess, they present with a certain type of symptoms, a certain symptomatology, a certain patterns, you know. And when the same neurotransmitters are diminished, they present with another presentation and more of the withdrawn phase of that disorder, right? So remember dopamine, excessive dopamine, right? Psychoticism, delusions, and sometimes delusions are very uncomfortable to think about, you know, and when excessive dopamine, you sort of think about a horror story, right? Excessive dopamine sounds like a horror movie, right? And excessive norepinephrine is more like when you hear the at the end of the Super Bowl, right when they win the Super Bowl, hey, hey, where you going after the Super Bowl? I'm going to Disney World, right? That's like what I sort of like think about stories when there's excessive amounts of norepinephrine, and then I start thinking things like mania, right? Mania, you know. And again, it may not even be mania. It may be that the person is simply mismatched with the environment at the time. And the people who are slow are referring it to as mania because it makes them feel better. But when you think about excessive norepinephrine, think about mania, you know. And then here we're going to do the one on serotonin, excessive serotonin, love, things like that, right? Affection and things like that, falling in love, you know, the sense of warmness, you know, sense of oneness, unity. And of course, low level of serotonin, depression, and anxiety, right? So we're going to go over the serotonin receptor. And let's see here. So I have here. Okay, let me see here. Or is this one better? This one's bigger. That's big. Good. Okay, how about this one? Okay, so this is just a free grok, and you can use anyone you want. Explaining serotonin receptors. Okay, let's see what we get here. I hope I'm connected. Let me turn a little music off here. Okay, let's see. Explaining serotonin receptor. Look, distribution here. Serotonin receptors are found in the central nervous system, the brain and spinal cord. Also in the peripheral nervous system, other tissues like the gut. Remember, you give SSRIs and things like that, they can have like GI upset right there. Blood vessels, remember lightheadedness, dizziness, high hypotension. It can cause those as side effects. Changes in your cardiac arrhythmia, things like that. Okay, the various locations explain, the various locations explain serotonin's wide range effects. Okay, so that's why this is the distribution to other tissues is one of the reasons why you get side effects and why they present the way they do. So whenever I give patients with these SSRIs, watch out for any lightheadedness, nausea, vomiting, or dizziness, things like that. So let's get into it. Okay, so serotonin receptors are a group of proteins found on cell surfaces that bind to serotonin, right? 5-hydroxytryptamine, okay, or 5-HT. The neurotransmitter involves in regulating, mood, sleep, appetite, memory, and other physiological processes. Remember appetite. So these receptors are responsible for these like domains of functions, just like mood, like sleep, like appetite, like memory, and other physiological processes like weight gain and things like that, energy level, interest, and things like that. But isn't this all of the symptoms of depression, right? When you ask someone about depression, don't you ask about mood? How you're sleeping? I'm not sleeping well. I can't fall asleep, or it takes too long to fall asleep, or I'm sleeping too much and really tired. Memory, hey, it's impacting my memory. I can't think about things, and other physiological processes like weight loss or weight gain, things like that. So you can see the symptoms of the Siggy caps. I guess the symptoms of depression are basically attached to the domains of things that this receptor is responsible for. So these receptors are critical for maintaining serotonin's effects on the body and brain, right? Okay, there are 7 main families of serotonin receptors, H1 through 7, with multiple subtypes, 5-HT1A, 5-HT2B, things like this, making at least a total of 14 known receptors. Right, okay, so there's at least a total of 14 known serotonin receptors. Okay, each play a distinct role and location, distinct role, then they're located at certain locations, and then they have slightly different mechanisms. So I don't want to go into the details of this, but let me just go through the distribution here. So these at 5-HT1 receptors are generally inhibitory, right? It reduces neuronal activity. Okay, look at this one. I think it's 5-18. Which is the other one? Yep, okay, 5 right here. And 5-HT5 receptors are also inhibitory. So the inhibitory receptors, if I can remember correctly, HT1 and 5. So these are all inhibitory, and they decrease neuronal activity. Less understood, but likely inhibitory. Okay. Now, the H2, the other receptors, excitatory, increase neuronal activity, causing the fast excitatory response. Okay, 4, stimulatory, enhances GI cognitive motility and cognitive function. Excitatory, 5, inhibitory. And I think the 6, is it excitatory too? Yeah, I'm not sure about this one. 7, excitatory. So remember, 14 total receptors, 2 categories, 1 and 5 are like inhibitory, the other ones are sort of excitatory. And so if you're thinking about if someone presents with depression, a significant amount of anxiety, sort of think about these serotonergic networks being somewhat hypoactive, right? And so we'll need to sort of activate these networks, and so they're more active and get more transmission. If we get more transmission across these networks, then the lobe is carrying out its responsibility better, right? Okay, so here, those are the two types. Okay, so remember we were same thing with the receptors and the networks and the proteins, all that. Two types, the ion gated channels, and then the G protein channels, the ionotropic and metabotropic sort of pathways. Here it is here. The duality presents right here also, because you see the G protein receptors and ligand gated ion channels. So G protein receptors, most serotonin receptors, 3 are G protein receptors, right? So remember, around 14 of these receptors, at least 14 of the receptors, most of the serotonin receptors, except 3, are G proteins, which trigger intracellular signaling pathways, including cyclic AMP or calcium release when serotonin binds, meaning it alters the cell functioning. This is very important because remember, the ion-gated channels are important in the signal in initiating action potential, and that form of communication that almost happens instantly. But then the G protein is this is the process that allows the signal transduction pathway, and that's where we're going to actually create a specific message for the cell body to produce a product. And when it says altering gene function, when the serotonin binds to the receptor, it goes through the signal transduction pathway and produces a product that's then exported from the cell. Then that's when you get an alteration in cell function. Ligand-gated channels, these allow rapid inflow of sodium across the membrane, calling immediate and neuronal excitation. So here, okay, the physiological and clinical relevance, mood and mental health. 5, 1, and 2 receptors are key targets for antidepressants. Okay, 5-HT1A, 5-HT1-2, they increase serotonin availability, right? Great. 3 and 4, GI. Okay, 6 and 7, neurological disorders. Many drugs, including psychedelics, migraine medications, sumatriptans, and antiemetics, target specific serotonergic receptors. Makes sense. Okay, distribution. Oh, we got through that pretty fast. Okay, and let me see if you have any questions now. Just ask any questions if you have it. So this is for the serotonin receptor. Okay. We look at the serotonin molecule. I'm going to see if we can do that. I won't be able to go through this. I remember organic chemistry. Okay, let me see here. Even if I read this, I wouldn't understand it. so let me move on. It's so disconnected from what I do. I was hoping, let me see if I can find an image of this serotonin. Okay, maybe this is the source. Okay. All right. Serotonin is also known as 5-hydroxytryptamine. Has a molecular formula here. Features 5. Okay. Yeah. This is okay. Yeah. Let me skip that too. Okay. Let me review the SSRI medications. Okay. I don't know if that's, I meant SSRIs. Okay. Okay, so we use SSRIs for the primary treatment for major depressive disorder, depressions, and anxieties. And it's believed that it's hypoactivity in these networks. And so we use a category of medications called selective serotonin reuptake inhibitors. These basically turn off the reuptake pump that's located on the presynaptic cell. When you don't get as much reuptake of the serotonin from the synaptic cleft into the cell, then more of the serotonin, the tighter increases in the synaptic cleft, and the larger the titer, then hopefully we can increase the transmission. So that's the thought, the thoughts behind it. There are classes of antidepressants that work primarily by blocking serotonin transporters, which increase serotonergic level in the synaptic cleft, enhancing serotonergic transmission. This mechanism helps alleviate the symptoms of a major depressive disorder, anxiety disorder, OCD, PTSD, and other conditions. SSRIs are considered a first-line treatment for depression due to their efficacy, relatively favorable side effect profile, and lower toxicity compared to tricyclic antidepressants and MAOs. Mechanism here. SSRIs selectively inhibit serotonin reuptake with a minimal effect on other neurotransmitters, reducing side effects compared to less selective drugs. They primarily interact with serotonin receptors indirectly by increasing available serotonin, which then activates receptors like the 5-HT1A and the 5-HT2A. Okay, so it's approved for major depression, generalized anxiety disorder, social anxiety disorder, panic disorders, OCD, PTSD, and also premenstrual dysphoric disorder. Side effects: lightheadedness, nausea, vomiting, dizziness, some sexual dysfunction, decreased libido, possible weight gain, typical side effect profile. But look, side effects. SSRIs different half-life. A metabolism is via the cytochrome P450 system, mainly the 2D6 and the 3,4,A pathways, and drugs, and interacts with potential drugs. Yeah, see, Prozac has the longest half-life, is days to week. They even have a tablet like called Prozac Weekly. You take once or more. There's some versions that have a half-life less than 24 hours. Okay, so here's another thing that you may want to find interesting here. This is a list of SSRIs ordered by potency, right? The strongest ones first, because if you're in an outpatient setting, if you have someone with like a major depressive disorder, but it doesn't seem to be maybe on the mild to moderate spectrum, then you want to use the less potent ones. And for the ones that may experience treatment refractory, or things like that, or if their depression is mediated by something other than serotonin, then you may want to go with one of these stronger, more potent SSRIs. So here, Paxil, I mean, this is really Paxil is very good medication. It works very well. It's very potent medication. We give it at night because it can lead to some sedation and dry mouth. It's used for major depressive disorders, OCD, particularly OCD, and PTSD and things like that. 60 milligrams a day, half-life less than 21 hours. Yeah, you have to prepare your patients with Paxil too, because it can cause a lot of anxiety when you're starting it. Zoloft. Okay, here's the KI. The affinity here is 0.13, 0.29. What that is. Okay, then we have Celexa, right? Escitalopram, Lexapro right here. Fluoxetine, Prozac. Yeah. Luvox, citalopram. Yeah. Celexa, one of the weakest ones, right? Paxil, one of the strongest. So look, Paxil, Zoloft, Lexapro, Prozac, Zolin. Well, now the atypical. Now, let me look at the atypical things later. And I think that's all I wanted to do for now. We went over the serotonin receptor, tried to go through the molecules, diagnosis. I think that's it for now. Okay, guys, I think that's all I'm going to do for today. I'll leave it there. We're at 20 minutes. I don't want to go too far over 20 minutes. But if you have any questions for me, please leave them in the comment section. And please like, subscribe, and share. Read out. It's been a pleasure, guys. Take care. Ciao. Good afternoon, everybody. Reed here. We're going to have a very interesting discussion today. This discussion is on borderline personality disorder. I'll teach you everything you need to know about it. This is a very interesting condition, and we're going to go into the mechanisms of the disruption, the parts of the brains that are not working well, and hopefully you get a better understanding of borderline personality disorder, and most importantly, the degree of suffering that patients with this condition have. I compare borderline personality disorder with the experience of people with borderline personality disorders as sort of being trapped on the roller coaster and you can't get off, right? And the thing about this, they describe a quality is that you don't know when the next ride is going to start, right? That's why they say, don't trigger me, right? And then have you ever noticed people who've been dealing with a lot of trauma, when they become triggered, they sort of begin to sort of recognize the process. They can sort of look at themselves. And you know what they say? You set me off. Why you set me off? What do they say? Why you got me messed up, right? You started me on that ride, right? Why did you start me on this roller coaster? And now, no matter how this thing goes, I'm on it and I can't get off of it. So that means you triggered my ride, right? You triggered my ride, right? In order for the word trigger to make sense as a description of the whole process, is the entire process have to have some tension in it, meaning someone had to push you up the roller coaster, right? And you recognize you there, say, please don't cut the cord, because when I go on this ride, it's going to be difficult for me. You're talking about mood disturbances all the way to severe depression, all the way up to extreme highs like grandiosity and things like that, euphoria, those extreme highs. And so that ride is, okay, most of us live within a certain reasonable range, but some of us have the capacity to have moods outside of the range that everyone expects. And when it becomes in these high and low areas, they are very uncomfortable. So trigger means that, hey, you're gonna release your occupancy at this level, and you're gonna experience the whole range of human emotions. They will feel the full range of emotions, and that's not good. How do you work with rage, right? How do you pay attention with severe depression? How do you pay attention to hopelessness? And so when we look at the mood category with borderline personality disorder, they feel the full range of emotions. In addition, the great deal of stress that they're under creates more of a hyperaginergic state where they're always on the guard, like always, like uptight and always kindled. That state is uncomfortable for them, right? And it results in like a distorted perception of the world. They begin to perceive things differently, under those states of psychological and emotional distress. So we see in borderline personality disorder, perceptual disturbances. They perceive things differently, of course. And that perception changes, right? Remember, if the person is experiencing rage, that's one interpretation of the world, right? But if they're experiencing severe depression, that's a different interpretation, right? And if they're really happy with you and euphoric, that's a different interpretation. So in many cases, you'll see many people with borderline personality presenting very differently in different settings. Like, you look completely different. I don't even recognize you in the picture. I don't recognize you in the photo. I don't recognize you in the picture. I don't even recognize you with me, right? So even though they can have the huge perceptual changes, it's, they believe whatever reality they're in. So this spectrum that they bounce up and down on mood and perception and even cognitive function, attention, concentration, and things like that, they can go from becoming very inattentive and easily distracted, unable to focus, to hyperattention, when they're stalking you, hypertensive, hyperactive, focused, driven, motivated, all those things. So even on that motivation spectrum, they bounce around constantly within these different categories, and I think that the name borderline was sort of developed because you really don't know what's going on. You don't really know if the person is being emotionally and psychologically abused or they're just psychotic. So maybe they're on the borderline of both of neurosis and psychosis. Neurotic means you're going to do what you're going to do anyway, despite what anybody tells you. Really say, hey, you shouldn't do that, and they go do it anyway. You shouldn't do that. They don't do it anyway, right? You tell them, hey, you tell them, hey, you did this to me. No, I didn't. I saw you. Something was wrong with your eyes. You got cataracts, right? So these people, another thing. So we're going to get into borderline personality disorder, and hopefully we'll get into like the mechanisms that creates it, the pathophysiology, and also the treatments, things like that. And I think after you got an understanding of this disorder, I think you would empathize with people with this disorder more. I think when you really understand how this condition is created, I think you would empathize with these people. They undergo a great deal of emotional, psychological, and sexual abuse at very early ages. And that is very damaging to any developing mind. And so at the heart of it, these are some of the unprotected victims. Can I say that? Yeah. And these are the most people who've been harmed the most, to the point where their emotional growth has been stunted, right? And so it's important to sort of understand the process, and when you engage with them, to have empathy with the struggles they're going through. And when you see them in the emotional, psychological pain, it's best to respect that pain, right? And it's better to take what they have to say as the truth, as opposed to just saying, oh, okay, yeah, it's just you again, So these are very important patients of mine, and I really enjoy taking care of them. So our discussion, this is going to be on borderline personality disorder, but also I want to recognize a lot of people I work with. I'm a psychiatrist, and I use a lot of sitters, and I use the sitters to watch the patient, to sit with the patients and accompany the patients during their hospitalization. I work with an incredibly excellent group of people, and I couldn't be more proud of the work that we are doing with our patients. So all of these years, I wanted to at least have the opportunity to thank a lot of the sitters that I've been working with over these years. And I'm going to see if I can pay for like chicken wings on Friday or something like that. So I want to see if I can give back to the sitters that I work with. And you guys been great working with you over years. I don't think that the experience with taking care of patients would be the same if it wasn't for you. And in fact, my patients always give me really good reviews on our sitters. So I at least wanted to recognize that I do appreciate the contribution you're creating to the team. And I also wanted to reiterate the importance you play on the treatment team. You are a very valuable part of the treatment team, and I want you to know that. And so I'm going to see about at least planning the chicken wings for lunch on every Fridays or something like that. And hopefully that can encourage more sitters to reflect the highest standard of patient care. You know, what we want to do is ultimately we want to provide the best service possible. Why? Because I want people to be able to see the work that we're doing, look at our documentation, look at our patients, look at our educational program, look at the resources, see how much we're doing to try to help provide very valuable service to the South Side of Chicago. I'm not sure if there's anyone on the South Side of Chicago who's more dedicated to taking care of his family than me, than his patients than me. The South Side is a very important part of this nation. South Side is very important. So it's very important that the residents on the South Side, all of Chicago, but mainly at the places I'm working at, it's very important that you receive the highest quality of care, right? The highest quality. This is 2025, not 1960. So you shouldn't get 1960s care. Right. So I would like to thank the sitters overall for all the help that they've been helping with over these years. It's been great. And I'm going to see if I can find ways to support you more in the future. Okay, great. So with this, first, let me go ahead and go to my discussion on borderline personality disorder. So let's see here. Okay. Okay, I don't want to go to YouTube. Let me go to, Google. Explain borderline personality disorder. First, let me give you an overview of how this works first. This may be helpful for you. Okay. When we're born, remember I described people being on a roller coaster they cannot get off? That roller coaster is the ego, right? And so how does the ego create the highs and how does it create the lows? Believe it or not, it just says so. It says you depressed and therefore you feel depressed. It says you happy, therefore you feel happy. That's how it works. It's that simple, right? It's just that simple. So when a patient with borderline personality disorder experience their ego assigning anger to them, after it reads the situation, it assigns anger. With growth, the individual grows and has the capacity to say, hey, I disagree with the assignment of anger. I disagree. When you do that for the first time independently, you've done something very important. You've actually escaped your ego for the first time and you're watching it. So for example, if the ego is the roller coaster and you keep sitting in the seat and somebody has to switch to turn it on all the time and you have to keep going on the ride, that's awful. At some point, somebody like me step on your, pat you on the shoulder and say, hey, you can always get off the roller coaster, meaning unbuckle the seat, get out the seat. That way, if they trigger that process, it can go on, but you can just watch it, right? See, this is the most important thing for you to know, that you can actually, you don't need to accept the mood or anything that your ego tells you. You have the option to disagree. If you disagree, then you are watching and monitoring the apparatus that controls your whole reality. That's the ultimate form of healing, is to watch everything, but not get involved. And when it goes bad, you just look at it. Oh man, shake your head, keep going. And that's all it is. But you go back and investigate and try to change things. And you get meaning you get back on the ride, right? So borderline personality disorder are people who don't know that they can get off the ride or their willpower isn't strong enough to pull them off the seat. The game itself has an alluring quality to it, where it sucks you in, where every patient with borderline personality disorder they want just one more ride, right? But that ride is dangerous, right? So when they learn to just look at the emotion, oh, I'm feeling depressed. Oh, my ego is making me feel the emotion of depression. I wonder how long it's going to make me feel this way, but I'm not depressed. When you get a chance to do that, you've healed. You have your armor, you have your shield, and there's nothing anybody can do to you. And you're bulletproof at that point. When you look at all of those around you and everything, you can say, I don't care what they say. I'm me. And then you know you're healed, right? So that's the goal. When I treat patients with borderline personality disorder, I say, hey, you don't need to get up. Hey, you need to leave. You need to move. You need to go someplace where there's not roller coasters, right? And please don't get on another one. And if you choose to get on another roller coaster, then when it starts bouncing you back and forth, don't start yelling at me. Get off the roller coaster, right? Sometimes we may have to give them medications so that the roller coaster isn't as alluring, so it doesn't pull them in as much. We can give them mood stabilizers, right? Because if they're really, really, really depressed, the fluctuations on the roller coaster can finally give them an opportunity to feel better. It's programmed steps in the roller coasters, right? Remember the cycle of violence, there's honeymoons. If every cycle of violence, there's honeymoons, right? Same thing with emotional psychological abuse. There are cycles of it. They have to come back with a good time. Otherwise, how are they going to lure you back? How are they going to create the magnetism to lure you back to the roller coaster? And you know what? Roller coasters are the example. That's the perfect example because they line up to get on a roller coaster just to get scared. And what do? Ah! Right? Same thing. So when you're born, that roller coaster is the ego. You're born with a primitive ego, meaning it's only a switching mechanism. It's good or bad, good or bad, good or bad, good or bad. Remember the old Atari in the graphics? You can see the cubes the man were made of. That's how the primitive ego presents the world, right? Okay, but then when you grow emotionally, these two poles become more integrated, right? It becomes more a structure like this, more actually structure like this. Well, actually, like that. Well, you know what I'm talking about. And that means that someone can be bad and good at the same time. Someone could, like a parent could feed you and discipline you, right? If the parents feed you, doesn't mean that they're good. They're just feeding you. If they're disciplining, doesn't mean they're bad. They're setting boundaries, right? So either way, you can have a parent set boundaries and say, hey, my mom still loves me or my dad still loves me, as opposed to they're evil because they set boundaries towards me, right? So patients with borderline personality disorders are ultimately the ones who've had their emotional development stunted at a very early age. And the swings, the highs and lows reflect probably the age that they were age of emotional and psychological development at that time. So the trauma stunts, halts, damages, or distinguishes that internal sense of self that forms that internal identity and the self-esteem. Now, remember, narcissists, psychopaths, and sociopaths, they always have to target your self-esteem. So they always say things, he's like this, she's like that, he's like this, she's like that, because they want you to participate in targeting someone, and eventually they want to damage that person's internalized sense of self. When they damage the person's internalized sense of self, they regress from their adult state down to where they were when they damaged, and then now they start acting out, right? So patients with borderline personality disorders are the ones who are almost stunted in their growth, so they continue to behave as at a developmentally inappropriate age, younger age. So they begin to develop begin to engage with people at the at the age that they were damaged. Now, this is dangerous. It's dangerous because when they regress to the early developmental stage, they no longer have the same toolbox of an adult. So they can't reason like an adult. They cannot rationalize like an adult. It's really a 6-year-old, and this person only have the tools of a 6-year-old to handle all of their problems, right? Let me show you the tools of a 6-year-old. Right? Primitive defense mechanisms. So let me show you this. When you understand this, it's a very you sort of understand how people work. You listen to certain things and then you run and you never go back. You never talk to them. You never talk about them. Nothing. You just leave, quietly leave, because the people who have these primitive defense mechanisms, they're very dangerous, right? Here, examples of primitive defense mechanisms: denial, people refusing to accept reality, right? Projection, people attributing one's own unacceptable thoughts, feelings, and impulses to another person. Remember when people start rumors and things like that? Rumors are based upon projections. They're really talking about all the things that they can't handle. So all the damage that happened to them at their earlier age, where they're really angry at their primary caretakers, they can't take it out on them. What they do is they suppress it, and they suppress it and they push it out of awareness. They don't want to think about it. But then it becomes too much. And now, in order for them to get relief from their suffering, they have to project their psychological trauma onto you and then say, you. That's why the narcs always do this in privacy. They have to tell each person in privacy. If it were true, get on a microphone and say it, right? Let everybody know. See, the narc has to do this in secrecy because the content is about the narc, not about the person. So when you see projections, people starting rumors or participating in rumors, this is a very serious thing. You should run from these people. You shouldn't say anything about it. Just be quiet. Splitting. Viewing people or situations in extremes, all or nothing terms, rather than integrated positive and negative qualities. Splitting, people start rumors, start splitting people and don't want people communicating together. Here, regression, that is when they return to an earlier, more childlike stage of development in response to stress. What do children do when they become under stress? Yeah. Talking, always talking, right? What do you do when coming stress? And what do adults do? Sit down, shut up. And the children talking constantly. Acting out. Expressing unconscious feelings by behaving impulsively rather than reacting on them. Dissociation, detaching from reality by separate thoughts, consciousness, and or identities. So borderline, so these are the primitive defense mechanisms that young people, that we're all born into. But as we continue to mature, we stop doing those things. And we have to consciously stop doing those things. Why? Because we don't want the suffering they produce, right? Using these primitive defense mechanisms come to a cost. Chaos, disruption. Everybody's fighting around each other. That's how you identify this, the primitives, right? So borderline personality disorders are people who've experienced this stunting in their emotional and psychological development. And the people who tend to be stuck on the ride, who can't unbuckle the seat on the roller coasters, are the ones who are locked into the primitive defense mechanisms. Meaning that the primitive defense mechanism is the basic psychological toolbox to exist as a human. But just because you have it doesn't make you human, right? Hold on a second. but it doesn't make you human. These people lack empathy, right? Which is a very important human quality. So you see a human-like figure walking around expressing primitive defense mechanisms with no empathy. That means there's no way they can get off that ride. Meaning they're going to bring everybody else on the ride, right? They're on it by themselves. And so they have to do whatever they need to do to get you and everybody else on the ride, right? That tension back and forth between alluring you on, yeah, this is not going to scare you. Come on in. You're like, this is not going to rattle your brain. Come on in. Like, this is not going to harm you. Come on in. Like, I need company. I need companionship. I'm on this ride all alone. That's why they spend so much time and effort trying to groom you and to listen to them. They don't want you to listen to anybody else, right? They're stuck on this ride and they want you to get on it too, right? So borderline personality disorder is a mental health condition characterized by intense emotional instability, right? Impulsive behavior, right? Impulsivity, right? Remember, good or bad. There's a huge gap between good or bad. Let's say you're doing one thing at one moment, then the person changed their mind and now they want to do something else, right? Are we in love or not? Are we friends or not? What? We're enemies, right? Okay, difficulty regulating relationships. Well, good or bad, right? Okay, symptoms: intense and rapidly shifting emotions, right? Difficulty controlling anger and impulsivity, right? Chronic fear of emptiness and boredom, right? Fear of abandonment, right? Black and white thinking, self-harm, distorted self-image, right? These are all sort of, if you look at a 6-year-old child, this is all they're doing, right? And because they're 6, we tolerate that, right? But what happens at 30 years later and still doing the same cluster behavior as a child? The only difference, they're bigger, so we don't look at the behavior as being the exact same thing as impulsive children. But if you look at it, it is. Look, rapid, intense shifting emotion, because your reality is different based if you're splitting. If things are all bad, then that's one world. If things are all good, that's a different reality. These are two different realities. And when your reality shifts, when you are in the presence of another person who maintains their same reality, that's a lot, right? But this is the ego. Difficulty controlling and impulsivity, right? Remember that? This is that mesocortical pathway, right? Feelings of chronic emptiness and boredom, that mesolimbic pathway, the reward pathway, hypoactive. Fear of abandonment, intense need for relationship. That's that diminished serotonin, increased anxiety, separation anxiety, and things like that. Black and white thinking, idealizing the value, primitive defense mechanism, self-injury, self-coping mechanisms, distorted self-image, and identity issues. Remember, this is the target. The people who damaged this person, this was the target here. This was the target here, and you damage this, then all of this is simply a result of that. That's why they focus so much to try to damage your internalized sense of self. Okay, causes. The exact cause is unknown, but is believed to be a complex interaction between genetic, environmental, and developmental factors. Look, genetic factors. There are certain gene combinations that promote instability in the mesocortical, mesolimbic, these pathways. And if you don't have stability of those pathways, when they fluctuate, you're going to go on the rides, right? So look here, risk factors. Look, childhood trauma and abuse, particularly sexual abuse, right? Family history of mental illness. I'm doing a series on narcissism as a network, and I'm doing a series for the South Side Chicago called Narcissistic Black Family Cults. So if you're looking at some of the families that are engaged in a lot of the violence and a lot of the things, the gossip forming organizations, stalking you, all this stuff is nuts. When I began to look at this, I began to look at the concept of narcissistic Black family cults. When the whole family is headed by a narcissist, they simply create more narcissists. Diagnosis: BPT is typically diagnosed in adolescence, early childhood, right? Okay. It involves a combination of therapies. DBT, okay, focus on developing skills for managing emotion, improving relationships, and reducing self-harm. Managing emotions, right? Improving relationships, reducing self-harm. That's DBT, right? CBT helps individuals identify changes in maladaptive patterns and behaviors. So this DBT this is sort of functional. It helps you sort of maintain your relationships and things like that. But cognitive behavior therapy is sort of like trying to reprogram your ego. So some of the things you believe that the sociopaths around you instilled in you for their benefits, you don't need to believe that anymore. And you certainly don't need to follow your ego when your ego sends you in that direction. Right? Then you have to understand, at some point, you're going to need to understand the difference. Okay, medications. Remember, the mood stabilizers sort of raises the action potential. It decreases the traffic along these networks, and overall has more of an inhibitory, diminishing effect on the brain. So mood stabilizers such as Depakote is an excellent choice. Other medications like lithium. Lithium is associated with decreased suicidality. So I always try to start lithium in patients with borderline personality disorder. It also helps with cognitive functioning and things like that. Let me see. Okay, let me go explain the if you're a student that's new here, let me show you. Look at some of the videos I created. It'll help you. Let me see. I'm gonna show you some videos that can help you. Hopefully you can. Okay, let me see here. Okay, I'm looking for. Look at this video on the mesocortical pathway. The video on the medical, okay, great. Here's the mesolimbic, okay, great. Here's the mesocortical, mesocortical pathway. Take a look at this video here for schizophrenia, autism, and then mesocortical pathway. Take a look at that. Also, take a look at this mesolimbic pathway, the mesolimbic pathway here. Now, if you understood those two pathways, then all of this stuff, all of the medications would make sense, right? Because when you understand the receptors on those pathways, and you understand when those pathways malfunction, what symptoms they present with, then you can see that they're coming up here. So instead of chasing all these irrelevant symptoms that can appear in different combinations and different diagnoses, you can sort of funnel down to the root causes of these, and that is the network is either hyperactive or it's hypoactive. If it's hyperactive, it produces these types of clusters in all of them. It doesn't matter what receptor in all of them, what network in all of them. And when it's hypoactive, it produces similar deficits. So the medication for borderline personality disorder focuses on the treatment specific, like depression, anxiety, mood swings, and impulsivity. So yeah, rather than the disorder itself. Yep, makes sense. You're treating the symptoms. But for me, I'm trying to stabilize those networks. Commonly prescribed categories include mood stabilizers, like discussed, right? Antidepressants, SSRIs, and antipsychotics. each targeting different aspects of the condition, such as aggression, distortion, and emotional instability. So that's one of the reasons why I wanted you to go back and look at those pathways, and it'll make sense why you want to prescribe certain medications. Okay, so symptoms, the medications are used to manage the symptoms, such as mood swings, depression, anxiety, aggression, impulsivity, and psychotic-like symptoms. It's not a cure. Mood stabilizer, yep. Lamictal, lamotrigine, and Depakote. Yep. I would go with Depakote first, and then I would also include lithium in here. I'll include lithium in here. Antidepressants, the SSRIs. Okay. Now, you may have to use a tricyclic antidepressant if the SSRI don't work. Remember, the antipsychotics is going to work on this mesocortical, mesolimbic pathway. So remember, it's distorted thinking, anger, paranoia, particularly during acute episodes. Anti-anxiety still. I wouldn't go with I would stay away from benzodiazepines in this population because this long-term anxiety use, I'm concerned about the risk of dependency on there. So I typically never start benzodiazepines in patients with personality disorders or things like that, because I think that they're going to have to find a better way other than a pill to sort of manage the situations that lead to the chronic torment. And I think the benzodiazepines are used to escape torment. I think they're very valuable for these patients, but if some of them are so effective that they can become a crutch. Okay, important considerations. Okay, and so those are the mood, those are the things right there. Okay, so now let me see if I can take a few questions. Is there anything else I wanted to do on borderline personality? Actually, let me do a peer review. Let me just let me see what they recommend as treatment. I want to look for the mechanism of injury, and the disturbances are primarily caused by dysregulation at the level of the frontal lobe, and the frontal lobe is the seat of executive functioning. When patients with borderline personality disorders experience a great deal of torment, they can experience what's called a frontal release, meaning the stress becomes so much for them that the arteries that supply the blood to the forebrain, the frontal lobe, it can dilate, right? And so when this artery dilates, the blood pools from the frontal lobe, and you have basically an oxygen deficit. So you get the huge acute loss of frontal lobe inhibition over all of these processes. And it's the frontal release that's thought to create the disinhibition. Then you get the rage, you get the anger, you get the irritableness, and you get the self-injury. So there's a kindling process that they can experience before their triggering process takes place. And so that process to me has always sort of described more like the kindling process that may take place in seizures and things like that. So I always try to help the patients understand that experience, and then try to magnify the experience and walk through it step by step. And it helps them understand that, hey, if we can prevent the kindling, we can prevent the explosion. And so the point is, you have to make sure the blood is getting supplied to all the areas of your brain. When you get into that conflict, it can get so intense, you squeeze the blood out of your brain. When you squeeze the blood out of your brain, it becomes hypoxic. When it's hypoxic, it fails. When it fails, you pop off. They get it. They get it. So let me say here, explain the Okay, explain the pathology and failure in borderline personality disorder. I want to get to the blood supply and see what they have there. Oop, hope y'all didn't hear that. Okay, let me see here. Okay, I wanted to get into the pathology, like the neuropsychiatry. Okay, vulnerabilities. Okay, individuals with BPT are born with a heightened emotional sensitivity that affects their neurobiological system. I don't think anything's born with heightened emotional sensitivity. You're tortured at a young. These people are damaged. These people are injured, tortured as young children. There's not a heightened sensitivity. Emotional, okay. Intense emotional response. Okay, yeah. Slow to return emotional behavior. Right. This described victim shaming. This described how the victim wasn't impervious to the emotional psychological abuse. Okay, invalidating environment. Yeah. Okay, yeah, here's the vulnerabilities. Yeah. Okay. Invalidating environment, right? The individual with his biological sensitivity is then raised in a chronically invalidating environment. See, this is very important. Remember I was describing how the ego has two components. One is an internal component, and the second one is an external component like this, right? The external component forms first, and you integrate all of these different elements to form your internal component. And these narcissists, psychopaths, and sociopaths always understand this in detail. That's why they always have to start rumors, right? So they're trying to target someone, and they're trying to do it in a very cruel and unusual way. These people are psychopaths, right? Because what they're doing, they understand that it takes a while for the internal sense to grow. So the person is dependent upon the external ego. So what narcissists, psychopaths, and sociopaths do, they go behind your back to each one of these and basically say you're crazy or start forming rumors about you. And if this person can get other people to reflect they're trying to create a chronically invalidating environment where the people who come around you always give you the responses that you don't expect, that you don't understand, and it's not consistent with how you're engaging with the world. You're out there, you have empathy. You're engaged with the world with empathy, and you expect the people to engage with you honestly backwards. But remember, the narcissist went behind each one of these people directly, either intimidating them directly or targeting them so that they don't engage with you honestly. So they go through the process of destroying your external ego, right? Basically, that's like them having the capacity to remove your garage door without you knowing it. So you at home, and every time you look at the garage door, it seems like it's a door there, because you wouldn't think no one would actually remove your door and put a fake 3D mirage there like a real door. But they went through all that stuff to do that, right? So with patients with borderline personality disorder, usually these narcissists, psychopaths, and sociopaths are constantly around them, grooming people to target them. And these narcissists do this compulsively. I mean, this goes on for years or decades, and you watch them still doing the same thing because they're unconscious, right? So this is the crime, and then you see these people doing these things everywhere. So, this is very important too. Listen, when you cannot get ahead, when things seems to be more complicated, when you feel like you're not being understood, this is these people working behind you, behind the scenes on your external ego, right? Now, it exacerbates the biological vulnerability. Here's the strategy. Let's see here. All right. Okay. Remember, we're all born at the bottom and then we grow. If people can manipulate the people around you that forms your external ego, then they can increase significant emotional and psychological distress upon you in the presence of everyone, and no one will have an idea of the severe emotional, psychological torment or torture that the person is putting you in amongst everybody. And of course, the psychopath has to be there watching, right? There's another quality to this, that the psychopath is always there watching. If they're there not watching, they have like someone in their groom, they're watching. But they're trying to damage you emotionally so you get trapped in the primitive defense mechanisms. And when you get trapped in the primitive defense mechanism, this is all you can do, right? That means they've trapped you on the ride with them. They lured you on there. They buckled your seatbelt in, and they're behind you, keeping you secure to the seat so you can't get off. And while you're on that road, this is the only thing that you can do. When you partner or listen to a narcissist, psychopath, or sociopath, you are one, right? And you are on their level. Why? That's why they came to you, right? That's why they came to you. They want to know if you can do these things, the primitives, right? And they come to you in secrecy and silence, right? The narc don't want anybody to know what he or she's saying. All that's private, right? So I hope that's a very useful explanation on borderline personality disorder. These invalidating. Oh, okay. Here, I didn't finish this. Invalidating environment. Look, responds inconsistently or inappropriately to the child's private emotions or experience. If you ever seen or experienced this, this is just awful. Have you ever been around one of these psychopaths or sociopaths when you've done something and then they give you the exact opposite response? So, for example, if you accomplish something, they will never acknowledge it. They'll change the subject as soon as they can. Or if you insist, they'll put you down. That's not significant, right? That's this, or inappropriately. You have to learn to recognize this, because when you're around these narcs and you're in a group, they'll say things that invalidate what you have to say. All right, now I'm back in business. Okay, so here, respond inconsistently or inappropriately. You ever had the friend that smiles in your face and talk about you behind your back, right? Or never react or support any of the things that you do positive? Yeah, this is it. Fail to teach the child how to know a label or regulate their emotional arousal. Yeah, this is significant, because these type of parents, they allow their children to sort of exist in so much stress and discomfort and provide them no relief. This is awful. I recall listening to some of Michael Jackson's videos when he described his life as a child, and it's incredibly alienating and isolating. And they ensure, these people ensure that you're isolated and no one can come to your help. Okay, reinforce extreme emotional displays while ignoring or punishing the more sable expression. Yeah, reinforce extreme emotions, right? While ignoring or punishing more subtle expressions. See, remember when I told you that the ego is first two pieces? The external form is the primary, the parents and the primary group, and then your community and things like that. And then you internalize many of those values. So what narcissists, psychopaths, and sociopaths do, particularly to their children, and it could likely result in a borderline personality disorder. They do these emotional and psychological abusive tactics. So, for example, they love you when you're doing bad things, and they don't like you when you're doing good things, right? And so they sort of steer the child towards the behaviors that put them at the most risk and will likely create the most damage. They set these narcissists, psychopaths, and sociopaths, they set their own children up for failure, because the children can only internalize the most sick and psychopathic things, right? So if you are only internalizing all these things when they're in a relationship with you, right? They really cannot provide, they really only can do the same thing. However, they hide it from you. They can only behave like this, but then they put a veneer on They put a mask on, and this mask is flashy, talky, always got to be in control of the scenario, always got to be the main character, cannot shut up, cannot sit down, cannot be in the back of the room observing. These idiots always have to be the drum major. They always have to control reality, right? And so when you see these people, they present as characters, trying to be likable, trying to be the most liked, trying to be the most funny. You see what I'm saying? Trying to be the coolest or something like that. You know, if anyone else challenged for those titles, then they go for the throat. They go for the jugular. This vicious cycle prevents the child from learning healthy emotional coping mechanisms. No coping mechanisms. And reinforce patterns of emotional dysregulation, meaning they'll likely do the disruptive behavior. They'll likely do the behaviors that would get them in trouble because they were groomed to believe that is the strategy that will help them, right? So narcissists, psychopaths, and sociopaths damage their children by having them internalize the rules that set them up for failure. So, for example, they will reinforce extreme emotional displays, such as reward you for your violence, but then prevent you from going to school. Right? Okay. Now, they are hoping that you internalize the dysfunctional behavior because you then become programmed. They become programmed as your handler. And when you internalize their value, now they don't have to watch you anymore. All they have to do is make a phone call or a text, and there can be long times of communication between the victim and the narcissist. In this case, a person with borderline personality disorder, the narcissist, they don't have to be much communication, but all the time, but that relationship is there, sort of like superposition, right? But not when one is up, the other one, no matter where it's at, the other one is down, right? So I think like this: when this is up, when the narc is up, then the clown is up. The clown is up, right? That will perpetually damage them, harm them, destroy their life, and basically have them perpetually seeking reunification with the narcissist, psychopath, or sociopath who damaged them in the first place. It's awful. It's sadistic. It's awful. They understand this. They intentionally have internalized things. That's why narcissists always have to lie to you all the time. When they're lying to you, they're actually putting wrong information into the networks. I did a podcast on why the narcissists have to lie all the time. And basically, they're trying to reprogram your super ego. And once you see that in real time, it's amazing. When they come in front of you and intentionally tell you a lie, but you can't let them know that you're conscious, that you know what they're doing. You simply watch them and like, wow, man, he's trying to brainwash me. And just go ahead and let them do it, right? And just follow them to see how long they'll do it. But it's amazing to see them sitting in front of you, putting on this act, and you know it's artificial. And they always had that cheesy smile, that cheesy grin. You always see them with the cheesy grin. Let me see. Okay. Relationship failures, right? Look, idealization and devaluing. Remember idealization, the honeymoon, devaluing, the breakup, the discard, right? Fear of abandonment. This is the number one issue with borderline personality disorder, fear of abandonment, because it's the same very early. They were stunned, they were damaged at such a very early developmental age. Childhood is fear of abandonment is the ultimate fear of childhood because they're totally reliant upon their caregivers. And this is where it goes. Very early on, they damage and traumatize people And the patient with borderline, look, an intense and chronic fear of being left or rejected, right? Left or rejected. Now, this is why the narcissist mainly always tries to alienate you from everyone. They want to try to precipitate this trauma that's likely there for the majority of people. They want to be included in the group. And so this is the first thing that the narcissists, psychopaths, and sociopaths are doing. When there is no evidence, drives fanatic efforts to avoid real or imagined abandonment. Now, this isn't, if you're in a relationship with a borderline personality disorder, this isn't necessarily a fear of abandonment with you. They can discard you. It's abandonment with the super narc who damaged them. So they cannot be disconnected from the super narc, because super narc is the one that cloned copied all of their values. They made a copy of it and they put it inside the child's ego. And now the child is behaving according to the rules that they gave them and to the perceptions that they gave them. And the child, in order to heal, the child would have to break away from all of those trainings and all this stuff and say, none of this stuff is real. That was just my sick mother, right? Or my sick father. Communication difficulties. This tactic that the narcissists use to target people's egos is so covert. Who would have thought of it? I mean, who would have understood that these sick people understand the ego better than you? You're taking this in a lecture, and these people get this by talking to each other. It's like a university for psychopaths that's running for free, where the courses they teach, they disseminate, and all this stuff for free. How could narcissists, psychopaths, and sociopaths teach all of these young people while they're growing up all of these sick things for free? And our educational system is having difficulty teaching them basic stuff like reading, writing, and all that stuff. And this is complicated, right? Instability and identity confusion. Yeah, look, there's the instability here because the roller coaster, right? Look, identity confusion, right? They don't know who they are. So for example, I'm a man, so there are certain things men don't do. so I'm a man, I'm just not going to do it, right? Identity confusion is if you lose that identity and then you start doing the things that you know that you don't do, right? Unstable self-interest. People with BPD have poor or unstable self-interest or self, leading to constant shifting goals, values, and career plans. Remember, their self-esteem is dependent upon who they are, is dependent upon the people around them. So if a person had a parent who damaged them, where they internalized the values that I'm nothing, then when they go to college and start engaging with the people, no matter how kind or how welcoming the people are, they're still going to feel that, listen, I don't deserve this. I'm not good enough for this. Y'all are too. Y'all are better than me. Right? Chronic feelings of emptiness and sense that they don't know who they are. Right? Impulsive, self-destructive. Remember the ego, impulsivity, that their frontal lobe failure. Impulsivity is the hallmark, often manifested a potentially self-damaging act like reckless spending, binge eating, untreated sex, sexual abuse, dangerous driving, right? Recurrent self-harm and suicidality. Yeah, it's very difficult on these patients. Up to 75% of our individuals with BPD have a history of self-harm, and the suicide rate is significantly higher than the general population. Emotional and cognitive, emotional lability. Look, stress-related paranoia or dissociation. Remember I said this can get so bad that it starts to impact the mesocortical pathway. And when it starts to impact the mesocortical pathway, you start having all these symptoms of psychosis. And look at this, inappropriate intense anger, that temporal lobe and that amygdala, right? This is why I think that I always go with Depakote in these patients to be helpful with that. Look, trajectory of failure without treatment. How do you repair something that's working correctly? It's just that you would have never thought that there was a program at the beginning of the story, intentionally programming the person incorrectly, program them to constantly feel depression or sad or negative emotions if you're not with them or if you don't agree with them. That's a deeper level of sociopathy. So I think that's it for my discussion on borderline personality disorder. Let me see if I can just take a few questions and stuff like that. Thanks. Hey, freaking Flax. How's it going, buddy? What strategies can family use to better support a loved one with PD? Boundaries and stay out the movie. I suggest you don't get on the roller coaster to try to help. I suggest you stay off the roller coaster and just watch. Send messages. I suggest you don't do that because it's going to end up the same way it did the last 20 times, right? You're going to bust your head again, but I wouldn't rush in and try and save them. Rushing and trying to save them, you rush in and try to save them, they're going to lock you in on the seat. Hey, Maquina, how's it going, buddy? Very good point. Understanding the diagnosis may improve empathy for patients and their families. Yep, sounds good. I think that's all I have for today. It's been a pleasure to speak to everyone again. And I still want to send a shout out to all the sitters that I work with. I'm going to see about at least having fried chicken wings on Friday or something like that. But I do feel the need to reach out and see if I can support you guys as much as I can because you've given me so much support over these years. And I don't think I've had a chance to really step back and thank you for that. If it wasn't for you sitters, I don't think I'll be able to do the job that we're doing. So I really want to thank you in advance. And I hope you understand my lecture on the borderline personality disorder too. Hey, this is Reed here. I'm out here. My next podcast is going to be on Charlie Kirk and what it means for the South Side. I think it's going to be a significant issue. So stay tuned to that if you're interested. Take care, guys. Reed out. I'll talk to you later. Take care, guys. Reed Matrix. Ciao. See this in diagnosis, and I can only imagine how it presents to the patients and the families. I can imagine just a cluster of symptoms that seem to be somewhat not connected to each other. I don't think that you really sort of can get to the root cause unless you have to go from that symptom hierarchy all the way down and funnel down to their one causal point. And I think that's at the molecular level. And I think at the molecular level, simply understanding their networks and how they present, what they're responsible for, and how they present when they malfunction or they function too much. I think this is the way you sort of lead to the diagnosis. So we can look at these and trace them back to the pathways. And so that's why I've spent a lot of time early on sort of explaining the pathways and things like that. So you don't have to memorize 100 symptoms. You just, is this pathway hyperactive or underactive? Okay, so diagnosis involves a thorough medical history, I'm sure, physical exam, cognitive assessment, right? Because you're gonna have to look at that frontal lobe and see how well they can pay attention, how well they can concentrate, how well they can focus, with a lot of the attention, a concentration, all those things, multitasking, sequencing, completing tasks, and things like that. So you're going to have to look at, test them and see how well they perform. If they perform below average or significantly below average, then definitely that lobe is impacted. So we can do a neuropsych testing that's test the functionality of the lobe. So let's say we want to test the cognitive assessment, of course, the frontal lobe, right? So how much can you pay attention? How much can you concentrate? Can you multitask? Do you have divided attention, or you're unable to focus on what's in all of those things? Now, if you form within a normal level, then it doesn't affect that level. But if you perform below that level, then that's probably an area that's impacted. And then So the cognitive testing is look at the other areas besides the frontal lobe. Just test the prefrontal cortex. That's to see their working memory and abstract reasoning to see if they have access to abstract reasoning. If they perform well, then it may not be impacting that area. If they perform under the standard area, then it may be impacting that way, right? You can look at the hippocampus, do the motor examinations for the basal ganglia, check to see if there's any muscle stiffness or muscle tightening and things like that. So just by if you understand the network, just by the cognitive assessment, looking at them, you can sort of get a good idea of map the damage out and see where it's at, right? So here, it's like a visual. I can't wait. I work with some really good people, and many of the developers that I work with are fascinating, and I can't wait to sort of apply this to 3D modeling. Because if you perform low within the hippocampus, maybe I showed hippocampus volume being very low. So when you do your neuropsych testing, then hopefully the patients can sort of see the pattern of damage based upon the low functioning of those lobes. And so I think some of the changes coming up in healthcare, and I think some of the things we're going to try to introduce into the market are going to be very innovative. And I think the patients are going to really my patients are going to be really proud for the work that we're doing here, Okay, yeah, so cognitive assessments can give you an idea of the damage pattern, right? And if there's been no trauma, if there's been no drugs or anything like that, if there's been nothing that can damage these networks, and the patient has memory and cognitive problems, then I think you can rule out Parkinson's dementia. You can rule out Huntington's chorea. You can rule out Alzheimer's. You can rule out maybe not frontal temporal lobe dementia, but you can look at the spatial patterns of injuries and see, hey, that's nothing else but Lewy body. Nothing else but Lewy body causes these patterns, these irregular patterns of hypoactive brain parts, right? So let's do the cognitive assessment, and you can just examine them and talk to them and get a consensus here. This is okay. Imaging tests such as MRI or PET scan. Now, I'm not sure if it's going to show volume loss or changes. I'm not sure how it'll present there. There's no single definitive test. Yep. Yeah. Okay. Treatment. There's no cure. I can imagine, but the treatment helps manage symptoms, improve quality of life. Medications improve cognitive functioning, right? So you may need, if you do neuropsych testing or any type of cognitive testing and the frontal lobe is hypoactive, you may need to use stimulants to stimulate the frontal lobe to get it to become more active so they can have more access to executive functioning skills. So same thing in the other areas. If there are areas, other parts of the brain that seem to be, if the networks are connected to things like serotonin or norepinephrine, if the pattern of cognitive problems exist in those areas, then you may want to use antidepressants to support those systems to sort of help prop them up and get them to more of a normal range. So you want to increase the transmission of serotonin and norepinephrine in those regions that are depleted. Movement symptoms, sleep aids. Okay, yeah, sleep aids. You want to make sure they get to sleep. Antipsychotics, right? Remember, if it targeted at a mesocortical pathway, you may have to go here. Use cautiously due to the potential of side effects. And, so we, in work we do, we use this all the time. So therapy and support for patients, right? Okay, it's a serious condition with a significant impact on life expectancy. The average life expectancy after diagnosis is 5 to 7 years. I didn't realize that. Okay, let me see here. Let me see if I can take a few questions for now. If you have any questions, let me know, okay, guys? Here. Hey, Ihash, how's it going, buddy? How is Lewy body dementia diagnosed compared to other dementias? For me, it'll have to be a rule out. Definitely have to be a rule out. So let's look at the dementias. Remember in Alzheimer's dementia, it just involves the hippocampus. So it should only be memory. And it's a gradual process. But they have preserved executive functioning. They have preserved abstract reasoning skills. They have preserved cognitive skills at least in the early stages, right? Okay, so we can rule that out if the person has cognitive problems. Parkinson's dementia is primarily a movement disorder in the basal ganglia. So in the beginning, they still have their preserved cognitive functioning, preserved executive functioning, perceptual things, but they have problems moving, right? So in the early stage, that's movement, but the cognitive is preserved. However, when it progresses, just like in Alzheimer's, it starts involving the prefrontal cortex. So now you have perceptual disturbances and things like that. And then it can move interiorly and upwardly. So and then involving more of the forebrain in those structures. And now you have executive functioning difficulties when that disease process really gets to run its full course. You start to have those, but not in the beginning stages. In Huntington's chorea, remember you have the choreiform movement because of a lack of breaks, right? So if there was no movements like that, then it can't be choreiform movements. You also have vascular dementias with strokes and things like that. If it's not strokes, then that's probably not the diagnosis. But then you also have frontal temporal lobe dementia, which damage to the frontal lobe and damage to the temporal lobe causes the symptoms, but those are typically in some of the elderly patients, right? I don't know what age this Lewy body presents with, but I can imagine how it'll be difficult separating frontal temporal lobe dementia because the damage is to the frontal lobe and the temporal lobe. But in Lewy body, the damage can be anywhere. I mean, boom, right? The frontal lobe, the temporal lobe, the parietal lobe, the basal ganglia, the hippocampus, anywhere those Lewy bodies build up, it destroys the cells. And that's not good. When a cell dies, I can imagine billions of molecular molecules that are active burst into the spaces between the cells. And these are active molecular molecules. The cell dies and the content just spills out. And that's not good. It interferes with all of the other neighboring cells. And then someone has to clean all that up, right? Your immune system. So when the buildup of these products result in those neurons dying, the cellular content spills out, you get a mess. The immune system is called to clear it up. Do you know how the immune system gets there? It has to open up the blood-brain barrier. It has to open up the blood-brain barrier. And what happens when you open up the blood barrier? Everybody come in, right? Your brain is suspended in a fluid that I would say is sort of like holy water, I guess. I guess the only holy water, the holiest water I know, your nervous system is suspended in it. I mean, and everything is tightly regulated. And what happens when you open all these pores and everything from the serum comes into that space? It results in inflammation in that space. And well, that process is inflammation. And inflammation typically is disastrous for those areas. Right? Nothing works well if the whole electronic circuit is experiencing a area where the environment just completely changed. I can imagine how do electrochemical gradients work at that point? I mean, all of these other molecules binding and things like that. I don't know how it will work in it. And then the immune system comes in and start macrophaging things up. You know, you can imagine how that sector is not going to function well for a while. And this thing is building up everywhere, right? It's building up everywhere. Then you have serious porosity in your blood-brain barrier. And then how are you going to stabilize your nervous system? So can you see how the cognitive, so even with the poor executive functioning with the frontal lobe, attention, concentration, multitasking, sequencing like that, this Inflammation in this porous blood-brain barrier causes an overall diminishing, sore, withdrawn, lack of awareness of environment, sort of form like an apathy. It becomes more like a hypoactive delirium. It leads to confusion, disorganization, and all of a sudden, the person cannot think. And so the networks don't function anymore. And that's what we call a delirium. It's also called an altered mental status. And some of my medical buddies call it more like a metabolic encephalopathy. When it happens in the ICU, they say ICU psychosis. But the same thing, this inflammation made the blood-brain barrier porous, and that porosity makes it such that the networks don't work. And so you don't have thinking, right? And I think that's all I need to go to for now. It's 22 minutes. But let me see if I can answer any more questions. Thanks for the question I had. Let's see here. Hey, Shorts. I want to learn the mechanics that trigger panic attacks. How can we stay in 5D all the time? There is a lot that I am enjoying your videos. Well, thank you so much. Different subject. We talk about Louis body, Shorts lover, Louis body. All right, well, thank you, buddy. Okay, let me see. Here's your question. How can we stay in 5D all the time? You got to practice constantly. Practice. And how long do you have to practice? You have to practice till you never want to stop again. That's how you get there and stay there. You never want to stop again. Patel, hey Patel, how's it going? Is there a genetic or familial component to Lewy body dementia? I believe so. Let me see. Let me see. See, is there a genetic component? Yes, there is a genetic component to Lewy body's dementia, but most cases are not directly inherited. Genetic variants can increase the person's risk of LBD, but they do not guarantee that disease will occur. A combination of genetic and environmental factors. Key factors about the genetic component: sporadic versus familial. I didn't know all this was here with Lewy bodies. The majority of LBD cases are considered sporadic, meaning it have no known genetic cause or family. Familial cases are rare and often caused by mutations in specific genes. Okay, risk versus causation. Okay, shared versus, yeah, okay. Some risk. Okay, yeah. So, some risk factors, ApoE, GBA, whatever that is. I remember ApoE, but all this stuff. The answer to that is yes. Okay, I think that's it for now, guys. Please feel free to like, subscribe, and share. And tomorrow, I think I'm going to do on vascular dementia. And vascular dementia is a stroke, CVA. And can you imagine all the different locations you can have a stroke and how it can present with a dementia? And let me just tell you this in advance. There are two types. There are ones like on the surface, and then there are ones that the strokes that are deep in the brain. They create two different presentations. It's sort of important to sort of know the differences between those two. So also, you should probably refresh your blood supply, like the circular Willis and the internal carotid arteries and things like that. Familiarize yourself with those. I think it'll be very helpful. And so we'll look at that tomorrow. So I'll see you guys later. Reed, take care, guys. Ciao. Today, we're going to have a very interesting discussion. It's going to be on vascular dementia. We went through Alzheimer's dementia, Parkinson's dementia, Huntington's dementia, frontotemporal lobe dementia, Lewy body dementia. And now we're going to look at vascular dementia. Vascular dementia is a very complicated type of dementia to fix, to manage. Why? Because it has to do with blood vessel destruction, right? Strokes. So strokes produce vascular dementias. Two types of strokes. The vessel can pop and the blood can ooze out, hemorrhagic, or the boulder inside of the vessel can get occluded, and it's an occlusion, and so there's no more blood distal to the occlusion, and the occlusion is I forgot the name of stroke, not hemorrhagic, but embolic stroke, right? And I think it's important to understand the differences between the two, because you can imagine the treatment would be different. If you have a blood vessel oozing blood, I'm sure that's a different treatment modality than a blood vessel obstructed. But I'm a psychiatrist, and I'll leave that to the other guys to worry about. What we want to know is the impact that stroke is having on the person's ability to function. We're going to look at several things: memory, attention, concentration, executive functioning, abstract reasoning. We'll look at all those things when we try to characterize how severe this type of stroke is. And also, we're going to need to look at those things when we have to come up with a plan on exactly what we're going to do. Now, this is a very, very important area to be there for the patients when they have these types of events, because time is brain cells, right? We need to handle that right away. We need to get the blood supply back. We need to sort of stabilize those areas, right? Now, I'm on Google here. So let me see. Let me start off with the brain vessels. Let me see. Brain arteries. Okay. Which one? Try this one. Try this one. No. Let me go back to this one. I'm trying to do all the free stuff. Let me review this again. Great. Remember we looked at the temporal lobe, right? Remember the frontal lobe, temporal lobe here, Broca's area, sort of language, sort of interpretation of things, Remember temporal lobe seizures and epilepsy, rage, is temporal lobe connected very closely to the amygdala. So the amygdala gives it a lot of meaning and things like that. So this is where the fits of rage can come in. This frontal lobe, and we wanted to that prefrontal cortex, this area around here, this seat of abstract reasoning, right? It doesn't really show the prefrontal cortex here. And it's hard to really show a line demarcating the prefrontal cortex because it's only the area. If you probe the prefrontal cortex, it does not result in any type of muscular movement, right? And then we have the frontal lobe here, which is the seat of our executive functioning. So look at all the different points of all the different points where something can go wrong. If you get something like an occlusion here or something like that in this main truck, it'll cut off the supply to all the tributaries downstream. If you get obstruction distal, then hopefully it wouldn't be severe, right? Let's see here. So this is what we're talking about here. So a vascular dementia is when one of these vessels become occluded or pop, and it results in destruction and damage to the tissue around it. Now, this destruction results in inflammation. And remember, inflammation is the enemy. Well, inflammation is not the enemy. Inflammation is the process that sort of try to restore balance here. But what's happened is, in order for the inflammation to sort of restore balance, it has to make the blood-brain barrier porous. So you go from a semi-permeable membrane to a membrane with huge gaps in it. And what happens? All the content gets into the CFS and it interferes with the functioning of all the networking around it, right? So vascular dementias are very serious, and you have to take them very seriously and do a very thorough evaluation, because it can involve a lot of different domains. Remember, up here, the executive functioning domain, so they can exist in a state called executive dysfunction, meaning no purposeful behavior, right? No attention, concentration, difficulty organizing, sequencing, things like that. So you'll see the cognitive decline, a diminishing SORM, lack of awareness of the environment. You start to see all these things, right? If it involves more of the prefrontal cortex, then they lose access to abstract reasoning, right? They become very concrete. Abstract reasoning means it's hard for them to put the little pieces together and see what it makes, right? Assemble all the pieces to a toy car comes in the box, right? So if you're concrete, you'll just see pieces of a car. You probably wouldn't know that you can assemble all the pieces together and you will have one car. 30 pieces make one car. Look at those pieces. Oh, that's one car. That's abstract reasoning. That's because of the processing that happens in the prefrontal cortex. Now, when strokes affect that area of the brain, the prefrontal cortex, of course, it's also the seat of working memory, right? So you get abstract reasoning, but working memory is your capacity to hold all of those items into your memory until you're able to do some type of computation. But you have to hold all the things in your memory before you sort of rearrange and try and see what this is, rearrange the blocks and the objects to sort of see what this is, right? But if your prefrontal cortex is damaged because of the stroke, then the person will be concrete and lack abstract reasoning. Here's the question I use to sort of test for that. What does it mean when I say people who live in glass houses should not throw stones? What does that mean? People who live in glass houses should not throw stones. Why? The stone would break the glass. That's concrete. Why? Because the stone would break the glass, Dr. Reed. That's why people who live in glass houses should not throw stones. So you see the deficit of abstract reasoning, you think, wow, man, I think this stroke is affecting the prefrontal cortex. If they couldn't pay attention or concentrate or anything like that, then you would think about more of the frontal lobe here. Exactly, if they're making impulsive decisions, decisions that behavior that's unusual or not typical, and also here in this frontal lobe, you also have the seat of more of your personality. Right? How do you handle your interpersonal relationships and things like that? So patients with hemorrhagic and embolic strokes can have significant personality changes. Remember frontal temporal lobe dementia? Remember the temporal area, the rage and the behavior disturbances, and the frontal lobe, the cognitive, attention, concentration services. Anything damage that lobe, it's not going to perform the function it was designed for, it was created for, it developed for, or evolved from. Let's look at another. Okay, if it involves the deeper structures, here, look at this basilar artery. The deeper structures here. If it involves the deeper structures here, then this is this area where there's hippocampus and things like that. The hippocampus and the temporal lobe up in here. If it involves this, it can damage the hippocampus, and the hippocampus is where you encode information about the environment. If you damage the arterial supply to the hippocampus, then again, inflammation, Inflammation is dangerous for information is disruptive for these tissues and their functionality. It's just, I guess, it's just like being on the highway when they have to actually shut some of the lanes down in order to make the repairs, right? Inflammation is something like that. You need to make these repairs, so you have to bring in all heavy equipment to do it. But while you're making those repairs, the whole thing doesn't really function well. I don't think anyone wants to go to work when their commute times increase by 2 hours, right? Well, in this case, you're not going to get as much blood supply in that area. And the inflammation is going to cause a lot of dysfunction in the hippocampus, meaning there's a risk. If it's too severe, there's a risk that a person can be on read-only mode. You know what read-only means? You can't add anything to the network. You can just read. When you say read, you can just look and see what the person's doing, but you can't, if you communicate with them, they're like, oh, yeah. They understand everything. They understand that, well, yeah. But then they simply won't remember it. Why? Because it's not going to get encoded on the hippocampus. If it's not going to be coded inside the networks and their memory, then it will not be processed as an experience. You only process things that are in the network, not outside of it, right? If an object has 10 pieces to it and your hippocampus can only code 2, when it goes to your information goes to your prefrontal cortex and things like that, you render a reality based upon the 2 items in your memory, not the other 8 that were never encoded. You got me? So the strokes people can present with very significant and severe memory problems. And we have to test for that. One of the ways we test for that is to test memory, right? You test a person's memory. Let's see. I think that's clear. Let's see. So let me go here. So let me go ahead and look up vascular dementia. Explain. Explain vascular dementia. Okay. Remember we went through like the different receptors and the different networks. I think you're going to really need to rely on that conceptual understanding of those networks in order to think your way through these type of problems. Because you're going to have to test the different parts yourself. And if you know how these networks are regulated, then you have a good idea of what class and categories of medications to use. Once you drill down on the category of medications and look at the different receptor profiles and things like that, and then see which one you think will match up best for this. Some of the patients may require more potent antipsychotics, more potent medications. Some of them may not. Some of them may require medications that's more stimulating, right? So you have to in order to sort of provide just very good and detailed care for these patients, you have to tailor your treatment plan to exactly what's fitting their scenario and their situation, And it's an intellectual exercise to do, but it's very rewarding when you get it right because you can see a change right away, right? The networks may become destabilized and may malfunction because of the stroke. And if it's a hemorrhagic stroke, then you have blood in the CNS. Blood in the CNS? What? The cerebrospinal fluid is depressed. I think it's holy water, right? Cerebrospinal fluid got to be the holy water because the nervous system is suspended in it, right? The vessel pops and all the blood starts gushing out, and that's toxic. That's too much for this system. So you can see how the blood itself causes other problems. And how are you going to get all that stuff out? And where is it all going to go? Right? I mean, I think the body's going to have a difficult time, a challenging time trying to clean all that up in order to get things functioning well. And then how are you going to get the inflammation? I mean, what happens with the inflammation? You know, vascular dementia sets up a situation where the tissue damage, the hemorrhagic strokes, and even the embolic strokes causes chronic inflammation. Now, chronic inflammation creates the same challenges that we spoke about before, right? Chronically with a diminishing form, chronically with a lack of awareness environment, inattentive, difficulty focusing, unable to, very easily distracted, and things like that, can't really think much, and then you may see things like apathy sit in, decreased interest, decreased motivation, right? And so those are some of the changes that could result from the chronic inflammation secondary to a stroke. So we'll explain vascular dementia. Let's do this. Vascular dementia. Okay. A cognitive decline caused by damage to the blood vessels in the brain. That's it. Intellectual, y'all. Blood is reduced or interrupted. Brain cell death and cognitive impairment. More than just cognitive impairment, right? The impairment in mood, impairment in perception, right? Impairment in movement, like move your body, movement, things like that. Left-sided weakness, right-sided weakness, paralysis. So it leads to all sorts of things. Cognitive changes are just one we talked about. Stroke, small vessel disease. I only mentioned one. Stroke, blockage, or rupture. Right. Look, small vessel disease. Narrowing or blockage of small vessels in the brain. Atherosclerotic plaques. Build up of plaques on the arterial walls, which can block the blood flow. Let me explain this. This combination, look, high blood pressure, prolonged high blood pressure can damage vessels in the brain. Patients with diabetes, atherosclerotic plaques, prolonged, very poorly controlled high blood pressure, and or some type of substance abuse like cocaine, which causes vasoconstriction. And the moment the vasoconstriction can occur up to hours, 10, 12, 15 hours. And that's going to significantly reduce the blood supply to those regions of the brain. You get like hypoxic brain injuries from the decrease in the oxygenation of those tissues. They become significantly injured. When those tissues become injured, what happens to the networks? They don't just fail, they become overactive. There's no regulation. They become overactive, then become underactive and overactive, and that's all they do, flicker on and off like that. And that's what happens to the tissues that's damaged downstream from these embolic events. People having strokes after using cocaine, right? That's another risk factor for vascular dementias. Look at this pathophysiology here. The buildup of the cholesterol plaques, right? Let me show you this. Let me see, show me the build. Y'all figure I can't type. I can't type and look at the same time. Okay. All right. There's an interesting story here. A very interesting story. I think this is it. Oh, I think this is a better one here. Yep, it's better. Okay, let me show you this. This narrowing increases, you get a decrease, increased pressure. What is it? Verrilli laws, decreased pressure. If it's a decreased circumference, the rate of the blood flow quickens in this area. when this plaque becomes too encrusted, it can develop flakes or parts where it's not homogeneous, right? This pumping can cause a plaque to break off, and then it goes downstream, right? Then it goes downstream. And these emboli are sort of like microscopic particles, sort of like very small grains of salt. And they go all the way down. They keep going until they're so small. They keep going until they block the very smallest arteries, right? And this thing is going on all the time with these cholesterol plaques. And let me show you if it happens in the common carotid. Let me see if I can get some images of it in the common carotid so you can see how serious this is. And sometimes we have to get a Doppler, right, to look to see how much is occluded or not. Here's the common carotid right here, right? And then here's the bifurcation from the internal carotid artery and the external carotid artery here. This area right here, yeah. This massage, like chiropractic massages and stuff like that. Other things that can cause dislodging of these plaques, and it goes downstream. And you can see if there is a embolic stroke, if it's large enough, it can block a huge tributary. So this is what we're talking about there. So here, this is the atherosclerotic plaques. And again, if you have narrowing or blockage, okay, look, blockage of small vessels in the brain. This is the process what I'm talking about. See, this atherosclerotic plaques actually creates a small vessel disease, and it shows up as like, I think, punctate lesions on a CT scan. I got a lacunar infarct on a CT scan, something like that. Let me review that part. But I showed that it does show up on a CT scan. If someone knows the answer, I think it shows up as lacunar infarcts. I said, okay, but the small vessel disease primarily could be significantly created by all of these small emboli that are breaking off from this atherosclerotic plaque. And of course, if you have very poorly controlled high blood pressure, of course, it's going to speed that process up. Now, if this is the distribution, these arteries are the distribution, is this the field to assess? This is going to be a doozy trying to look at the symptoms because they come from almost anywhere, right? Of course, memory loss, hippocampal, right? Hippocampus function, difficulty with problem-solving decision-making, right? Frontal lobe impairment, right? Confusion and disorientation, hippocampal failure, right? If your hippocampus isn't encoding any information, you're not updating anything from your environment. And so when your reality renders your reality, you believe it's real because it is real. Nothing's wrong. It's just that your reality, you don't have any information included about the environment. Everybody else in the environment is integrating the information. So they have one world, and there's the person with the difficulty is they live in a different world. And they're in the two worlds. And let me tell you, the two don't meet. They don't fit together well. Right? The ones with the higher capacity always have to adjust at the level of the person they're in and engage on that level. And you have to be respectful when you do that. Right? So that's the confusion, disorientation, hippocampal dysfunction. Slow processing speed, right? Frontal lobe and things, frontal lobe and the parietal lobe. The changes in mood and personality, mood, temporal lobe, that frontal lobe, right? Temporal lobe, rage, right? And personality, that frontal lobe, right? Difficulty with language and communication, temporal lobe, right? Walking problems and fall, basal ganglia, right? So that stroke, after you got to do a really good physical exam on a stroke, because you get a chance to see all the different parts that it's impacting. And what you're going to have to do, know the networking of each of those parts. Pick your tools. You're going to have to find a way to put this system back together again. Next is treatment, managing the underlying risk factor, lowering blood pressure, quit smoking, medications to improve blood flow, cognitive rehab therapy, supportive daily living. And so the treatments seem to make sense, don't they? Okay. The prognosis for vascular dementia depends on the severity of the damage and the underlying risk factors where the stroke took place, right? I'm reading this, even though my pen is over here, my red. I think I should go over this way. At least I'm looking this way. Okay. At least I'm looking towards the document. All right. Additional, this is the second most common type of dementia after Alzheimer's. Right. The second most type after Alzheimer's. It affects people of all ages, more common in adults, no cure, right? Treatment can manage the effects. Let me. So here's the brain, and then you can see how certain tributaries and things like that. Okay, a normal blood vessel. Oh, blood vessels with dementia? No, they could not blood vessels with dementia. It's not a good source here. With dementia. Okay, I don't think I need anything else. Let me see. And of course, the medication, I don't think I need to go on the medications because they're going to be depending on what you look at. Okay. And what you want to, okay. So I think that's it. I don't think I need to cover anything else for vascular dementia. Okay. So let me see if I can ask get a few questions in. Okay, guys. And then we're at 27 minutes. So I don't want it to go on too long here. Hey, Moeen, how's it going, buddy? Thanks for the questions. What makes vascular dementia different from Alzheimer's dementia? Remember, Alzheimer's is damage to the hippocampus. It's the muscarinic network. Remember, inside those cells in the hippocampus, they have the buildup of intracellular inclusion bodies called those tau proteins. And this is the waste, the intracellular waste. It builds up to the point where it can dislocate the whole cell body, this huge mound of waste. Destroys the brain cell. The brain cell dies, right? So it's a gradual buildup of debris inside the brain cell, so resulting in brain cell death. And it's a gradual transition. So it only affects the memory, right? Whereas vascular dementia, the strokes everywhere potentially, right? Okay, next, TJM. Hey, TJM, how's it going? Okay, what role do strokes and mini strokes play in vascular dementia? The strokes would be the huge ones that block arteries. But those mini strokes are the small microscopic cholesterol plaques that goes down, and it goes down and includes the very small blood vessels. And so the pathology at that point is at the end of the vascular tree at the smallest level, whereas the other embolic events may exclude whole trunks, things like that. So the location of the location where the pathology presents itself is different. Okay, I think that's all I need to do for today. It's been a pleasure, and I hope this has been very helpful for you guys. If this is interesting to you, please like, subscribe, and share. And I'm going to continue to add do these presentations. So it's a pleasure. Next, I want you to look through the video on the mesocortical pathway, also on the hippocampus for the acetylcholine muscarinic network, and the frontal lobe. And then I think once you review this vascular dementia and how you treat it, particularly if you view the networks, then you understand the network and you sort of understand how to select your medication with these. It's a pleasure. And until then, I'll see you guys later. Read out. Take care, guys. Ciao. Today is going to be a very interesting day. Hopefully I'm streaming into the unit today. So thank God if I'm able to get a chance to have my patients see me now, I mean, this is really accomplishment for us. We work very hard for this. I want to be able to bring my patients more information about their treatment. And so every day at noon, I'll be teaching the medical students and other students. Of course, we have a student program here. And I think I can use this as the streaming as an opportunity to start to teach the medical students and other students more about the disease processes and have the patients listen in on it. So this discussion now is more oriented towards the medical students and it's from the medical perspective. And so we're going to talk about the molecules, the receptors, the pathways, the things like that, the molecular biology underneath the science. And as a patient, you get a chance to listen to this, and what happens at the molecular level is amazing, That's why you see me very interested in these things. And so for the first time, I get a chance to verbalize what it's like internally, what it's like to do this type of work. Psychiatry is very complicated because everything is what you're interpreting and how you're reading things and stuff. And so we're just trying to do a better job, So if my patients can hear this, hey, we've gotten a victory today because I'm going to be bringing you more of the medical education this way. And also, you can go to my YouTube site podcast, Read Matrix. The matrix is your ego. And the ego is the structure that basically contains your consciousness and interprets everything for you. So my goal is to sort of help people deal with their mental health issues by learning to manage your ego and also kind of how to escape your ego. So it'd be interesting to talk about many of those things. So the subject is primarily directed towards the students. But if my patients have any questions, I believe I set up a way so that you should be able to ask questions. If not, then hopefully I'll have it set up next time. But I do want my patients to be able to ask any questions you want. And I'm doing this for you. I want to be able to give you more information and to empower you as much as possible. Another thing, I'll be in the process of opening up a walk-in clinic on the first floor at Jackson Park on the Stony Island side. So hopefully I can get it running between 8 in the morning to 8 in the afternoon, 7 days a week. So we're in the process of working on that. So hopefully that way, if you need me or contact at all, you can just come to the hospital in a walk-in clinic and be able to gain access to me right there to get refills or whatever you need from there. And also, I should be able to do direct admits from that point also. So I can get you medically cleared and things like that in my outpatient clinic, and then simply have you schedule a time to go through the emergency department, schedule a time to enter the emergency department, be evaluated, and then enter the unit. We're also, later this month, we're going to open up an online clinic. And so I'm going to have all my patients register online so they can get in direct contact with me. So hopefully just one button and I pop up on the screen, something like that. I'm trying to continue to eliminate the barriers between me and my patients, and so you can always get in direct contact with me. And you have my number anyway, 708-873-9059. If you're my patient, please feel free to call me at any time. And so the online clinic is going to be a innovation in this space because we're going to be focusing on medical clearance from the online platform. And so you should be able to get all of your evaluations. If it's not an emergency issue where you need to go into your emergency department, you should get all your evaluations and assessment online, and then I can help you get to the hospital you want to go to. So that our online clinic is going to be coming online soon. And if you would like to practice with me here at this hospital, I'd love to receive you. If there's any psychiatrist or medical doctor that's interested in practicing with me here, I would love to receive you. I think we have a very good program on Leapfrog. I think we got an A rating on Leapfrog, and I think we worked very hard for that. And we're safety net hospital with an A rating. So it shows that, with very hard work and determination that we can provide the same level of care as the big boys, doing it at a safety net hospital. And it makes it very good. So I'm looking forward to a lot of these changes. Okay. So 6 minutes. Okay. So let me go ahead and get into this. I began a series on networks, describing networks. The first network I described was the mesocortical pathway. The second was the mesolimbic pathway. Now, this structure we're about to talk about now is called the basal ganglia. The basal ganglia is a cluster of nuclei, subthalamic nuclei. And one of the primary roles it plays is responsible for movement, so motor movement. And so when we have difficulty or damage to the basal ganglia or its functioning, it results in movement disorders or movement problems. The basal ganglia is a highly dopaminergic neuron system. Death of the dopaminergic neurons actually lead to the dysfunction. So I have one of my idols, Muhammad Ali, and I'm sure you know about him. He was a famous boxer, and he developed Parkinson's disease, right? Seeing as a child, seeing how magnificent this man was, it's absolutely amazing. How much of a strong personality he was, it was sad to see him at an early age, around 30, start to develop symptoms of dementia. And it got, his Parkinson's dementia got pretty bad. So I'm going to try to link the functioning of the basal ganglia to, for the students, I'm trying to link the functioning of the basal ganglia to Muhammad Ali. So hopefully I hope you remember this content. Okay, so here, I looked up here on this AI search engine. Okay, how many punches to the head do you estimate Muhammad Ali received during his professional career? How many punches to the head? 29,000? 29,000 punches to the head. Punching people in the head leads to inflammation. And the inflammation isn't good. The problem with inflammation is it causes the blood-brain barrier to become porous. When the blood-brain barrier becomes porous, then all the content in the serum enters the cerebrospinal fluid. Now the machinery doesn't work at all. So if the nerve fibers cannot operate because there's debris in this field and things like that, then it presents like glitches and things like that. So it presents with confusion and disorientations, altered mental status, diminished and SORM, lack of awareness of environments, things like that. So can you imagine 29,000 punches? And this is someone who's trying to hit you as hard as they can. There's somebody hitting you at the full. These are strong men hitting your brain. And so those are different type of punches. Those are not everyday punches. And so you can imagine the recurring bouts of inflammation and then the accumulated injuries that would occur over time. The basal ganglia is located deep within the structure of the brain. So if I can give you, let's see. Okay. So here's Wikipedia. Here's the brain here. And it's this collection of subthalamic nuclei. And look where it's positioned. Right here is like the stalk, and it's here in the deep structures of the brain. Let me see if I can show you the inner surface of a skull. Let me see if I can. Okay, yeah, here. Okay, so here's I don't know if it's going to open up, but what I'm trying to show here, here's this bony region here, and there's not much room. The structures here are cavernous, and they're bony structures that are unforgiving. So when someone punches you in the head as hard as they can, your brain is like the sponge. And the damage can occur at the stalk, significant damage at the stalk where the basal ganglia is at, and the subnuclei of the basal ganglia is located at. And so 29,000 times. And if you can imagine the reoccurring bouts of inflammation and things like that. And so I in my opinion, the mechanism of injury for his basal ganglia was likely due to traumatic brain injury. Repeated inflammation, damages to the brain, repeated inflammation to the basal ganglia area, to those, and to the point where those nerve fibers, they began to die. And when those nerve fibers began to die, he couldn't move his muscles. And so he's like frozen. And so let me see if I can sort of give you an idea of how some of it looks here. Here's just the video. And do you see like the mass facies now? Yeah, you see the mass facies? Yeah, those cranial nerves are still innervated, controlled by the basal ganglia at that point. And if you have a death of dopaminergic neurons, then you have the loss of the decreased production of dopamine from the presynaptic receptors that are no longer there. And if you get decreased production of dopamine, then the entire dopaminergic network is hypoactive. And therefore, the movements are hypoactive. And we describe this as a psychomotor slowing or as a psychomotor retardation or something like that. So you can see here how the champ is, he's gone through some brain changes. And let me see here. Let me see if I can answer any questions at this point. Okay, great. Okay, Dylan, you have some pretty good questions. They're so in depth. I don't think I know the answers to those in-depth questions. So, let me see here. Okay, let's see here. Okay, let's see here. Hey, iHash, thanks for the question. What treatment approaches are available today that Ali did not have access to? Newer generation of medications that are more specific for targeting the networks. Newer medications. I don't want to go through those now. I don't want to get the students all mixed up. Okay, great. Felipe Furlan. Felipe Furlan all the way from Brazil, a little small town called Rio Claro, huh? Can I think of instead? Okay. Right, and so it's hard for Felipe is saying he's a developer. It's hard for him to think about 29,000 punches over a certain period of time. He think of it in terms of a flow, a punching rate. Awful, you're awful. Thanks for the question, Felipe. Hope I answered it. 29,000 punches from a professional boxer career are heavy to take. I don't even find that attractive as entertainment, and the thought of hitting someone and damaging their brain to win a game, it's too much for me. Next question. Can Parkinson's show up years after the damage began? Absolutely. Absolutely. It's thought that the Parkinson's is sort of the brains, the cells are die because of the buildup of tau power products or something like that, intra-inclusion bodies that build up to the point where it pops the cell wall and the cell die. So you have the buildup of debris inside of those cells in the area of the basal ganglia that actually result in the death of the brain cells. And we'll go through that mechanism a little bit later to show you how it does it. And then I think for here's with the champ here's inflammation, repeated about for inflammation. Now, when those brain cells die, they don't come back. And so I wonder if the area is insecure, meaning I think the blood-bearing barrier in the areas where you have damage may be, I don't know, I'm not sure if the blood-brain barrier can be repaired in those areas. So I think that you're going to constantly deal with altered mental status and mental status changes secondary to the inflammation. Okay. Can Parkinson's show up years after damage again? Yep. Okay. Next, Mohammed. Is Parkinson's always caused by trauma, or can it happen without head injuries? The mechanism for Parkinson's is basic, is the buildup of the inclusion bodies that result in the cell death. But in this case with Muhammad Ali, I'm thinking that inflammation played a role in it also. And the reason why is that he had other types of behavioral and other types of problems. Besides just movement. Okay. Did Ali's intense medical discipline slow down the progression of the disease? I would think the hyperdopaminergic state of a boxer would probably be too much for his hippocampus and the parts of his brain. So I think being in that state isn't good, that hyperaginergic state isn't good. And I think that being in that fight or flight modality causes damage to certain vulnerable area, particularly the hippocampus. That's why victims of chronic stress and abuse usually have memory and then begin to develop cognitive problems as a result of that. So I think that there's a vulnerability being in a fight of your life. And then, they're in situations where they get knocked unconscious. I mean, who goes to work and get knocked unconscious and then get up and then just shake it off? That whole fight or flight state is just not good. It's not good. Okay. And so I think that all of these were vulnerabilities set up from the start. Okay. Here, let's go ahead and look at the receptors on the basal ganglia. So after you sort of understand the receptors that are located on the basal ganglia and how they operate, then you sort of begin to understand exactly what medications to use to treat these disorders, right? And so the issue is the death of dopamine neurons in the basal ganglia, specifically in the area of substantia nigra. You can see it on autopsy when you look at it under methylene blue stains. So it's the loss of dopamine. It's dopamine hypoactivity, and this leads to the hypoactive network. So we need to do everything we can to increase dopamine, right? So we the enzyme that degrades dopamine, we need to turn that enzyme off, right? The enzyme that takes the dopamine and from the presynaptic cell that re-upstate the dopamine from the synaptic cleft into the presynaptic cell, we need to turn that pump off, and so that's basically the strategy here. Okay, so the receptor profiles in the basal ganglia. Okay. The basal ganglia contains a diverse array of neurotransmitter receptors, including, remember, dopamine, right? Okay. GABA. Remember, GABA is the main inhibitory present in all cells. Look, fortunately, we have that GABA there. Glutamate, remember, the excitatory neurotransmitter, glutamate. Of course, remember all the hyperactivity and agitation, combative and aggressiveness, right? And remember, we give benzodiazepines, Ativan, IM, to activate glutamate to sort of reduce the psychomotor agitation, combativeness, and aggressiveness. Remember we do that? And so here's that story: GABA to relax, glutamate excitation. And then look here, acetylcholine. Okay, and with patients with a cognitive deficit and dementias, even with agitation things, we also use Aricept to help with that. Okay, so here, of course, we have the dopamine 1 and 2 receptors. Here are GABA receptors, okay, chloride channel, glutamate receptors. All right, okay, here's the acetylcholine receptors, and these, additional receptors. Okay, and so, okay. So let's see. Okay. Okay, here's another question here. Hi, Umber. Okay, are there any treatments in the works to protect dopamine neurons in high-risk people like boxers? I don't think that's how they go about developing pharmaceuticals. Avoidance would be the solution. Avoidance would be the solution. Okay, let me move to the next question, next issue, okay? Okay, here, let me just review Parkinson's dementia real quick. I just went on Wikipedia just to get some general stuff. Here, Parkinson's disease dementia is a dementia associated with Parkinson's disease. That sounds circular to me. Together with dementia with Lewy bodies, it is one of the Lewy body dementias characterized by abnormal deposit of Lewy bodies in the brain. Okay, let me see the Lewy bodies. These are the inclusion bodies I was describing. Lewy bodies are inclusion bodies, abnormal aggregates of proteins that develop inside the neuron affected by Parkinson's disease. The Lewy body, in the Lewy body dementias and in several other disorders, such as multiple system atrophy, going off to other subjects. So here are the inclusion bodies that build up inside. It's like the debris that builds up inside of the neuron, and it piles up to the point where it can actually disrupt the membrane, the cell wall, because of them. Now, these you pick these Lewy bodies up, now the Lewy bodies are also present throughout other cells within and other parts and tissues within the brain. So simply because the Lewy bodies are present in a cell, that doesn't mean that it's going to have that detrimental effect of destroying the cell. So they're not sure. So when you look at how widely Lewy bodies are spread throughout the body, it's not sure exactly why some areas, particularly basal ganglia, degrade sooner. So it's not really clear why it's vulnerable to the basal ganglia. Basal ganglia is vulnerable to these inclusion bodies. Here, okay, the defining proteins component of Lewy bodies, the alpha forms the aggregate. Okay, so they're shown. Okay, Lewy bodies appear as spherical masses in the neuronal cytoplasm that can displace other cellular components such as the nucleus and neuromelanin. So yeah, this is what I was describing, is that this is like the debris if you think about the neuron as a molecular factory, then this is all the debris sort of piled up, and it can get so large. I didn't know it could actually displace the nucleus. I didn't know the pile got that big. As you can see, it can sort of rupture the wall. A given neuron may contain one or more Lewy bodies. Okay, so I can see how you can see how that can destroy these cells. Okay, let me see here. Okay. So if the Lewy bodies are destroying the dopamine producing cells, then that means that there's going to be less dopamine produced. And so the overall network is going to be hypoactive, which means the person is going to have psychomotor slowing and retardation, and they're not going to be able to move as much, right? Won't be as spontaneous. And so the goal is to increase the amount of dopamine. So we have to stop the dopamine from being broken down. We have to stop the dopamine from being retaken back up into the cell. And I think we have to also try to produce more dopamine. So carbidopa levodopa is a medication that's very helpful. And here it is. And let me just explain how this medication combo works. Very interesting. It's a lot we'll go through to try to get the drug to that target. Carbidopa levodopa is a combination medication used to treat Parkinson's disease. Its effectiveness relies on separate mechanism of actions of its two components. And this is very interesting stuff. Okay, so here's levodopa's role in dopamine synthesis. Here's carbidopa's role in optimizing levodopa's delivery. Okay. Dopamine deficiency in Parkinson's. Parkinson's disease is primarily caused by a depletion of dopamine in the brain. Right. That's what we said. Levodopa crosses the blood-brain barrier. Levodopa L-dopa is a precursor to dopamine that can cross the blood-brain barrier, unlike dopamine itself. And you see where I put my patients on those multivitamins and things like this. I want to make sure they have all the precursors to it. Sometimes they may be malnutrition to the extent where they don't have precursors. Okay, next, conversion of dopamine. Okay, once inside the brain, levodopa is converted to dopamine by the enzyme aromatic LAAD. Okay. Okay, also dopa decarboxylase. I recognize it as dopa decarboxylase. Replenishing dopamine stores. That is when the neuron, when the brain, the cell body starts to produce more of it. This conversion replenishes the depletion of the dopamine stores in the brain, helping alleviate the Parkinsonian tremors. Okay. All right, and so here's the levodopa component. Let's look at the carbidopa's component. Carbidopa's role in optimizing the delivery of levodopa. Again, preventing peripheral breakdown. When levodopa is administered alone, a significant portion of it is converted to dopamine in the periphery. That is outside of the brain, but you want dopamine in the brain, outside of the blood-brain barrier. You creating dopamine outside of the blood-brain barrier, outside of the brain, before it can reach the brain. This peripheral conversion of L-dopa leads to side effects and reduces the amount available to the brain. Okay. All right. So carbidopa inhibits the enzyme in the periphery. Carbidopa inhibits the enzyme dopa decarboxylase in the periphery, preventing the premature breakdown of levodopa outside of the central nervous system. And more levodopa reaches the brain. By preventing peripheral conversion, carbidopa ensures that a high percentage of the administered levodopa reaches the brain, and the brain can be converted to dopamine. Okay, we got that. Okay, great. So the inclusion bodies build up to the point where they can destroy the cell. fewer cells, fewer dopamine, and so we have to use the tool to increase the amount of dopamine in the interest and amount of dopamine in the synaptic cleft. Okay, let's see. And I think, okay, yeah, let me look at dopamine. This is the production, increasing the amount of dopamine. Let's look at dopamine metabolism real quick. And then I think I should take some more questions for you right there. Okay, dopamine metabolism in the synapse is primarily involved is reuptake into the presynaptic membrane, like we said that, neuron, okay, or degradation by MAO and COMAT. That's it. There they are right there. So those are the two enzymes that can break down and metabolize dopamine. Okay, so if that's it, okay, I don't want to go too long. It's 31 minutes so far. I don't want to go too long. Okay, so if anyone else have any questions at all, just let me know. Let's see here. Okay, here. Hey, John, thank you so much. Can Parkinson's show up years after brain damage? I would say yes. Is Parkinson always caused by trauma, or can it be caused by head injury? So Parkinson's is caused by the buildup of the intra-inclusion bodies that end up killing the cell and results in the decreased production of dopamine that makes the entire dopamine network hypoactive, and therefore makes the person very slow moving and immobile. So that's the mechanism of Parkinson's, based upon the intracellular inclusion bodies. But trauma creates damage and inflammation, and through, just like with Muhammad Ali, I believe there may have been a combination of both. It may have been the trauma with the presence of the intra-inclusion bodies in that area that all came together that created so much inflammation that his basal ganglia and those parts started to die off, and he started to get the symptoms. So the trauma would be a traumatic brain injury, creating the damage that way. So that would be a different diagnosis. It would be a traumatic brain injury, not Alzheimer's. But the symptoms are not Parkinson's, but if it were a traumatic brain injury with the movement part, then it's Parkinsonian-like symptoms, but it's caused by traumatic brain injury. Okay, next question here. Thank you, T-Jam. Did Ali's intense mental slow down progression? I think it did. Umber. Okay, I think that's really, I think I'm going through the same questions. Okay, so so that's it on my presentation on the basal ganglia. I hope it's helpful for everyone. Otherwise, I'll see you guys tomorrow. And for my patients, I hope you guys saw this. And if you did, I hope this is very helpful for you. If you have, go to my podcast, Read Matrix, and you can get the link to these. I'm going to start sending you guys the link to these videos, and I'm going to try to use this format to give you as much information as I can and make it accessible to you. So it's a pleasure talking to everyone. Thank you so much, and I'll talk to you guys later. Take care, guys. Weed out. Today, I'm going to finish up lecture series on the basal ganglia. And let me wait a few minutes, and I'll give some more people a few times to come in. And we had a chance to look at almost everything, a lot of these networks, and let me just review them quickly. Let me try to find the YouTube. Let me see if I can look at here I'm on my channel, Read Matrix here. Let me see if I can sort of review the discussions on the basal ganglia. So here, upcoming after this discussion, here is work on my series on narcissism as a network here, Shikari Richardson. Why the mental health system can't really protect you from narcs. Very interesting series to watch. But here, so you can see the basal ganglia. I believe I'm finished with that. We did the basal ganglia movement disorders. We went through that. Let's see, basal ganglia. We went through understanding Huntington's disease, the G proteins, basically the signaling molecules within the basal ganglia. Then we went through the basal ganglia, the key network and pathways. Okay, breaking down the basal ganglia again, Muhammad Ali and Parkinson's disease. Okay, anything else with the basal ganglia here? Basal ganglia here. Okay, I think that's it. So for today, I think I'm gonna finish up the discussion on the basal ganglia, and it's important for you to sort of adopt this behavior into your continuing medical education journey. So, after you study these particular areas, then I usually do a literature review on it to try to get a good idea of what's the most current research out there, what they're saying and things like that. It's a very interesting thing to do. And I'm going to show you how to do it very quickly, and it's not going to take much time. So, and this is how I'm going to stay up on what's going on. And for us, for now, I'm simply going to use a free resource. I'm going to go to simply Google Scholars. So let's get it in, okay? So here, let me just go here to Google Scholar. All right. Basic stuff, okay? Okay. Let's see. First, let me just go through a few things. I'm fine. Okay, so let's see here. Okay, this is 2025. Oh, 2 days ago. Oh, you get it in 3 days ago. This is the most current, huh? Neuronal intranuclear inclusion disease complicated by acute middle cerebral artery infarction. Remember, we're talking about those inclusion bodies and things like that. Let me see. Let me see what they're talking about here. Sounds interesting. Neuronal intranuclear inclusion disease complicated by acute. I didn't know there was a disease. There's a new disease. Oh, no, let me back up out of that. Let me back up out of the new disease section. Okay, I just want basal ganglia stuff. Statistical network models for flexible behavior. Finally, we will present our recent network modeling neuromodulation in the cortical basodhalamic loop during the flexible motif generation. Okay, whatever that is. Dynamic modeling of hippocampus basal ganglia interaction for septal navigation. Stuff's interesting. Forest disease. Okay, new diseases again. Diabetes. Okay, yeah. Increased frontal CT binding in Parkinson's disease patients with self-reported RMB. Teaching neuronal images. Maybe I need to sort of narrow my search down. Okay, related searches. So we went through, did we go through stroke? Okay, thalamus. We went through motor because we went through the networks, frontal basal ganglia, basal calcification. Okay, let me see here. Basal ganglia, what is this cortex? Let me see basal ganglia stroke. Providing explicit information disrupt implicit modulation after basal ganglia stroke. Providing explicit information disrupts implicit motor learning after basal ganglia stroke. Despite their purported neuroanatomic and functional isolation, empirical evidence suggests that sometimes conscious, explicit processes can influence implicit motor skill learning. Yeah, I think that's true. Our goal was to determine if the provision of explicit information affected implicit motor sequence learning after damage to the basal ganglia. Okay, I think that may be too much for its purposes. Movement disorders following cerebral lesion. But okay, I think that this is something useful for us. Movement disorders following cerebral. Okay, great. Okay, movement disorders are primarily associated with basal ganglia and the thalamus, right? Okay, therefore, movement disorders are frequently manifested after strokes compared with neurological injuries associated with other structures in the brain, right? Yeah. Overall clinical features such as types of movement disorders, the time of onset and prognosis are similar with movement disorders after stroke or other structures, right? Dystonias and choreas are commonly occurring post-stroke movement disorders due to basal ganglia circuits. And these disorders rarely present with tremor. Okay, hey, this is great. This is really interesting. Okay, here, rare movement disorders, including tics, restless leg syndrome, and whatever that is, can also develop from a stroke, right? Although the precise mechanism underlying the pathogenesis of these conditions have not been fully characterized. Disruption of the cross-sections between the inhibitory and excitatory circuits. Remember, the inhibitory, the direct, and the indirect pathway circuits resulting from vascular insults are proposed to be the underlying causes. So basically, interruptions of any of the pathways through the stroke is what causes the movement disorder. And I guess where is interrupting that? GABAergic and dopaminergic systems play a key role in post-stroke movement disorders, right? Yeah, the basal ganglia primarily dopaminergic, but have a lot of GABA receptors. This review summarized movement disorders induced by basal ganglia and thalamic strokes according to anatomical regions by which they manifest. Hey, I think this may be a good study for us to look at just for the next 10 minutes. Stuff like that. I'm afraid if I go back into the list, I don't think I'll find anything else. I don't want to blow my routine. I don't want to blow my lecture up. Okay. Great. Movement disorders manifest following a stroke are most frequently associated with lesions in the basal ganglia. That makes sense, right? That's where all the networking is at. And the thalamus is where all the switching is at. The probability of developing a movement disorder after infarction in deep nuclei infarction, such as one affecting the basal ganglia and thalamus, is 3 times greater than compared to surface infarction. Makes sense? Okay, let's see here. The frequency of post-stroke movement disorders. Okay, chorea. So both of these studies basically ranked the type of disorders in the same order. I guess this Ecuador stroke study didn't involve these other things, but look, chorea here, right? The rapid or sudden jerky movement. Dystonia, interference with the chorea is more like if you interfere with that intermediate pathway, or was a direct pathway for the chorea seen as Huntington's disease, and it's the injury to the direct pathway. Just check that out. I don't want to get them mixed up, but I think it's injury to the direct pathway. Okay, the dystonia, I guess the indirect pathway, one of those limb shaking, myoclonus, stereotypic movements, asterisks, tremors, that dysarthria, Parkinsonism, which is a range of sort of like slow moving symptoms. So this post-stroke movement disorders in the basal ganglia resulting in a range of movement disorders, highest being chorea and dystonia. Functional anatomy, here's that circuit again. Here's the circuit again, guys. Yep, same circuit, inhibitory to excitatory inhibitory to basal ganglia. Let's see if they have anything else here. Common reported movement disorders occurring after stroke. Okay. Onset career. Here's the same pattern here. Okay, look, career acute. Okay, but I remember going through this in neuroanatomy. Here it is again. And some after all these time, I still don't think I'm gonna memorize it. But here, located over in these sections. Yeah, memorize it, guys, for your USMLE step 3. Okay, hyperkinetic movement disorders. Right, yeah, hyperkinetics. Okay, remember the one similar to Huntington's disease. The hyperkinetic movement disorders have been described on the basis of basal ganglia modeling. Yeah, typically lesions in the substantia nigra, I think at STN, and decreases the excitation of the basal ganglia output and consequently reduces thalamic input. Yeah, you can go through that circuit. GABA and dopamine systems might contribute to post-stroke movement disorders. Of course, those are the neurotransmitters that run our systems. However, hyperkinetic movement disorders are relatively rare when the basal ganglia are markedly damaged. Yeah, if it's markedly damaged, then they're like things to be shut off. Involuntary movements arise after basal ganglia infarction, typically results from clearly defined lesions. Okay, great. Let me see here. Okay, the types of movement disorder. There's the chorea we're talking about. Okay, the dystonias we're talking about. Yeah, minus clonus. And so let's go into more descriptions of these tests. Let me see. And I didn't want to go too much into this, but I did want to let me go through one more briefly. And for the students, I'm just going to encourage you when you study this stuff. Right now we're like 13 minutes, and so I think you can go through like five, 6, or 7 really good studies just briefly to just get yourself familiar with what's going on out there. And I think it'll be a good idea to start doing it as you go on with your studies, because I think the research and studies very useful in keeping you up to date in your learning and remembering things like the neuroanatomy and things like that. Patients with stroke confined to basal ganglia have diminished response to rehab efforts. So strokes just confined to the basal ganglia, okay, may cause persistent corticothalamic basal ganglia interactions. Let me just see this briefly. Okay. Patients with basal ganglia internal capsule injury were more likely to have hypotonia, placid for paralysis, and persistently impaired balance and ambulation performance. While all patients had a comparable rehab experience, this result suggested that patients with strokes confined to the basal ganglia and in kernel capsule may benefit less from therapy. Isolated basal ganglia strokes may cause persistent corticothalamic basal ganglia interactions that are dysfunctional and impede interactions. Wow. Okay. So strokes that are defined within the basal ganglia internal capsule may make it more difficult for the patients to have some degree of rehab because I guess the hypotonia it produces. Okay. Systemic review and meta-analysis of word production abilities and dysfunctions in the basal ganglia. Okay. Yeah. Word fluency. Yeah. It'll be interesting to test word fluency in basal ganglia. Oh, wow. Basal ganglia small vessel disease and Parkinson's disease. So testing word frequency, systemic review, and meta-analysis of word production abilities in dysfunctions of the basal ganglia, such as stroke, small vessels disease, Parkinson's disease, and Huntington's disease. And what's the benefit? Yeah, I think you have to pay for this. Yeah. Get your hopes up high. Just stay in the free section. Okay, alterations in functional connectivity in stroke patients with basal ganglia damage and cortical impairments. alteration in functional connectivity. Wow. Okay, cognitive deficits following stroke and basal ganglia. Hey, just look at that. The objective to examine. Okay, oh, so the cookies. Objective, examine the effect of stroke in the basal ganglia on cognitive function. The results stress the notion that subcortical damage may lead to substantial neuropsychological disorders and have clear implications for neuropsychological rehab. Yeah, subcortical damage, yeah, damage in the basal ganglia. Okay. But I think that's it for now. So we're at 17 minutes. And so I just encourage you to start looking up on your studies every day, your studies as you go through this. And let me see if I have any questions, guys. So, hey, guys, thank you a lot for showing up. I appreciate everything. Thanks for the music, guys. Okay, let's see. Okay, let's see. Freaking Frax. Which disorders are more strongly linked to the basal ganglia dysfunction? Movement disorders. And I'm glad the literature review is showing us different types of, after some damage to the basal ganglia, it leads to strokes, the different types of movement disorders a person can have, the highest being choreas, the jerky movements and dystonias and things like that. Okay, and next is Umber. Hey, Umber, how you doing? Why does basal ganglia damage cause slow movements in Parkinson's, but excessive movement in Huntington's? In Huntington's, it's like the brakes are cut off. There's no inhibition, so there's nothing stopping the initiation of movements, right? And in Parkinson's, you get the buildup of the intra-inclusion bodies that eventually destroy the dopaminergic producing cell. When you get a death of enough cells in the basal ganglia, particularly in the substantia nigra, then you get less dopamine in the entire part of that substantia nigra. And so the whole network is hypodopaminergic because the brain cells, let's say if you start off with 100 brain cells and 30 of them die out, those 70 brain cells will still not be able to produce as much dopamine as the whole system. I think it's more like an issue like that. But thank you so much for your question. Okay. Hey, Nayab. Okay, Parkinson's, Huntington's, and dystonia are more related to basal ganglia in terms of mood disorder. Perfect, Nayab, just perfect. All right, guys, and that's all I really wanted to do for today. I'm almost at 20 minutes, and so let's go ahead and wrap it up today. And so if you have any questions, please let me know, but otherwise, read out. Take care of yourself. You have a nice day, guys. Ciao. Go ahead, turn the music down. Great. And so this next presentation discussion is about ecstasy. All right. And so we're going to talk about the mesolimbic pathway and ecstasy, the impact it has on ecstasy has on it. Let me just review a few things in the mesolimbic pathway. Okay, so let's say more specific, mesolimbic dopaminergic pathway. Remember, there's a cluster of receptors on the mesolimbic pathway, not only dopamine, but dopamine is the predominant neurotransmitter. And I believe, I'm glad I'm getting this diagram here. Remember, this is the mesocortical pathway here, and this is the mesolimbic pathway. The mesolimbic pathway is the pathway that's basically for the reward, motivation, and learning systems. When this pathway is hyperactive, you get all of those features sort of increasing, and this is the target for substances of abuse. When this network is hyperactive, such as in the case if in the case of withdrawal, or if someone's born with a pathway that appears to be somewhat hypoactive, then you have a lot of decreased interest, decreased motivation, decreased energy, difficulty getting started. things like that. Maybe difficulty remembering things. Okay, so this is the pathway that's the target for the drugs of reward. Let me look at the pathways, the receptors on it. Okay. Mesolimbic receptor profile right there. Great. Just to look at the receptors real quick. Okay, primarily involving dopamine, right? Ooh, that's mesocortical. Okay, VTA okay. Mesolimbic. Okay, here are the dopamine receptors. The 1, 2, 2, 3. Okay, now look at the other receptors. Here, serotonin receptors, opioid, oxytocin. Let me see. Okay, I thought there were also alpha adrenergic receptors on here too. Okay, well, let me see, NMDA cards. Let me see, NMDA receptors. Okay, the mesolimbic pathway in NMDA receptor plays a critical role in regulating dopamine release and are involved in the processes like reward, motivation, and addiction. Okay, yeah, so I was hoping my initial search would show the NMDA receptor, and then I would be able to connect that to ecstasy. So let me put ecstasy here. Here's a look at the mesolimbic receptor profile and influence on NMDA receptors in the context of ecstasy. All right. The mesolimbic pathway and NMDA receptors. The pathway is a crucial part of the brain reward system, heavily modulated by glutamate. All right. So remember, dopamine is a major neurotransmitter on the mesolimbic system, also glutamate there. This is the brain's primary excitatory neurotransmitter. Okay. NMDA receptors are the major type of glutamate receptor involved in various brain functions. So NMDA are types of glutamate receptors. Synaptic plasticity, neuronal excitability, and firing rates. This makes sense. Okay. The NMDA receptors are complexes, typically composed of 2 subunits and 2 regulatory units. Okay, that's to make up these huge G proteins. Okay, let's see the interaction between ecstasy and NMDA. Ecstasy is a psychoactive drug known to influence the mesolimbic system, primarily by increasing the release of monoamines such as dopamine and serotonin. Right. Research suggests that NMDA can also affect NMDA. So ecstasy, here it is right here. Ecstasy, MDMA. I can never get these right. NMDA, right? Okay. Okay, impact of glutaminergic transmission. Okay, so ecstasy can affect activity and expression of NMDA receptor subunits in the brain, like the forebrain cortex, caudate, putamen, and hypothalamus. And so glutamate causes activity and expression of NMDA, which is the glutaminergic receptor. Ecstasy causes the upregulation of glutaminergic receptors, and that creates a person who's very highly excitable. Okay, memory and cognitive functioning. Okay, MDMA, ecstasy, induce alterations in these type of glutamate receptors, alongside affects dopamine, and it may contribute to memory deficits. Involvement in areas of reward effects. Okay, NMDA receptors are thought to play a role in the rewarding effects of MDMA and in the resistance of drug-seeking behavior following abstinence. Yep, you see this? the reinstatement of drug-seeking behaviors following abstinence. That's a dopaminergic story. You know, people go places and be around places with people that they use substances with, and they get an increase in dopamine levels, and somehow through sort of like the conditional reward system, operant learning, the places activate the same sort of emotions in them. So if you stop using and went back to the locations where you use, you likely start to get those same feelings again. The potential for neurotoxicity, okay? While further research is needed, some studies suggest that MDMA's, ecstasy's effects on NMDA receptors and glutamate release may be linked to neurotoxicity, particularly in the hippocampus. And that's the whole point of what I was trying to get to today. We had several patients in their early 20s, and the first thing we wanted to say to them is, can you please leave ecstasy alone? Right? Because the ecstasy is MDMA, and it causes the release of a specific type of glutaminergic receptor called NMDA, something like that. Right? And when you activate that excitatory system, it's right till the wheels fall off. The ecstasy causes overexcitation that eventually results in the death of the brain cells. Accumulation of deaths in certain areas, particularly the hippocampus, is what we pick up. And these patients have difficulty functioning in school, functioning at work, staying employed, functioning in relationships because they can't remember things. And when we do the neuropsych testing that tests the parts of their memory, the hippocampus, they can score in a range of someone who's actually diagnosed with dementia. And this damage can progress. And so I'm not sure if the cognitive impairment secondary to ecstasy or MDMA's use, I don't know if it continues to create damages as even after use. Okay, so those are the receptors. Okay, let's see here. Next, let's look at the let's look at the pathways here. Let me show you another viewpoint of the brain, okay? Let me just see. Okay. Give me the brain, give me the brain, give me the brain. Okay. Okay, this is looking, here's the front, okay, anterior, posterior, okay? And this is like the left side of the brain. See the temporal lobe here, parietal lobe, frontal lobe. Sometimes okay. See, okay, I'm looking for the prefrontal cortex. Let me get off this page. Okay, I was trying to find. Okay, maybe this is I'll show the prefrontal cortex. So let me see if I can get to a few questions. Okay, first question is, good setup, Doc. Thank you, Nasir. Appreciate it, buddy. Okay, great setup, Doc. Thank you. Okay, let me see. So Jan, okay, Jam. Okay, how is the mesolimbic pathway involved in the love and euphoria people feel in ecstasy? Hyperactivity in the mesocortical pathway creates those positive and rewarding symptoms. I'm gonna say symptoms of mesocortical pathway hyperactivity. So symptoms of cocaine, methamphetamines. We reviewed cocaine, we reviewed methamphetamines. Now we're using ecstasy. All of these are targets for the mesocortical pathway, and they produce hyperactivity, or we get an improvement in all those symptoms that they wanted to target. Here, okay, hyperactivity in the mesocortical pathway, which is involved in cognitive functioning, so increased alertness, increased awareness, emotional regulations. They feel better, feel more alive, better attention, right? And better motivation, better exact planning, organization, and things like that. And so these are the benefits. Now, when we give patients stimulants, stimulants activate the frontal lobe. I have to, and I'm sure it also affects this mesolimbic pathway. I think there's some have is associated with learning, decreased interest, decreased motivation too. Okay, while often associated with deficiencies, mesocortical dopamine hyperactivity, particularly in the prefrontal cortex, can contribute to impulsivity, impaired decision-making, and difficulties with attention and concentration. Why? If you're blasting on that mesolimbic pathway and you're using all this ecstasy, it's going to turn everything up. And so remember, those dopamine receptors also on the mesocortical pathway. And I think activation of the mesocortical pathway is probably what interferes with these things here, because that mesocortical pathway extends, I think, all the way up to the frontal lobe. So it's a long pathway. And so, so the answer to that question is yes. Next is here's the next question here. Okay. Is the connection people feel on ecstasy real, or is it just a neurochemical trick? You mean, do I really love her, or is it just chemicals? It's chemicals. Is it? Is all it? That's the thing about the ego, is that it interprets all these things, and the activity of the network basically determines reality. All right. And so, but it's all based upon chemicals. None of the objects around us have any meaning to them, or they don't have any type of value to them. All the objects on this planet are basically the same. Okay, so it's a neurochemical trick. Everything is a neurochemical trick. And so the objects only have what you assign the meaning to the objects. The objects around you do not have any inherent meaning. And so everything what you assign to it. Okay, let me see the next one here. Can ecstasy lead to emotional numbness, wear off? It actually leads to withdrawals, hypoactivity in the network. Let me try to see if I can give you an example of that. Let's see. Can you show me Let me see if I can ask a question like this. I want a diagram that should show the presynaptic release of dopamine. And I think they simply use up all the vesicles. Okay, here. All right, the process of dopamine release from the presynaptic cell. So when ecstasy hits the receptor, it causes the release of dopamine. The process of dopamine release from the presynaptic cell. Dopamine is synthesized and is packaged, right? Now it's packaged into synaptic vesicles. Remember this, vascular monoamine transporter 2. These are very important vesicles because they package the dopamine, and they exist in that presynaptic bud, and they're ready for release. Okay, then you have the action potential comes around. When the action potential arrives at the presynaptic nerve, it depolarizes the membrane. Okay, calcium influx, right? This depolarization causes open voltage-gated calcium channels, causing the influx of calcium into the presynaptic terminal. right? The influx of calcium initiates the release process. Wow. Okay, vesicles docking and fusions. The increase in intracellular calcium triggers events similar to snare proteins. I got to look them up again. The protein helps tether the vesicles to the presynaptic membrane, docking and prepare for fusing. Wow. So it's a tethering system. Okay, exocytosis. When the snare complex assembled, the synaptic vessels fuse with the presynaptic membrane, releasing dopamine into the synaptic cleft. All right, then dopamine goes and it binds crosses and it binds the receptor. Dopamine binding to receptor. Dopamine molecules diffuse across the synaptic cleft and bind to the dopamine receptors on the presynaptic neurons, on the postsynaptic neuron, and the presynaptic autoreceptors. Binding to postsynaptic receptor generate a signal in the postsynaptic neurons. Okay, and then you have reuptake by the dopamine transporters. So yeah, okay, and so that's the mechanism. So my understanding with things like cocaine and cocaine is very potent in the release of these presynaptic stored dopamine, methamphetamines, and also ecstasy. So when you get that flushing of the dopamine out of the presynaptic cell, when that party's over, the whole network becomes hypoactive, and that's when they begin going into withdrawals. So when you come into the hospital and you see on the following day, it's very hard for them to actually take a history because they are so fatigued and tired. And I think this is this hypodopaminergic state that they're in. Great. And so let me see, let me have one more question here. Okay, I have Max on the line here. How do people become emotionally dependent on ecstasy, even if they were not physically addicted to it? Those these people who have mesolimbic systems that sort of exist more in a hypoactive state typically feels the anhedonia, the apathy, decreased interest, decreased motivation. And so when they take substances of abuse, that increases that network activity, they feel better. And that's the positive reward. The goal is to feel better, and the tool to feel better would be the substance. And so that's one of the reinforcing effects, because you want to feel better. And if they're not physically, even if they're not physically addicted to them, eventually this introducing these compounds into this system like that is going to interfere with its functioning. And I think that's what you're going to call some type of physical addiction to some extent. Okay, so I'm at the 26-minute mark. When we treat the medical complications connected to ecstasy use and provide supportive treatment, and you want to make sure you have the option to send the patient to neuropsych testing. For patients who use has a history of ecstasy use, I make sure that I get neuropsych testing to test their memory functioning, to test their prefrontal cortex, which is the seat of abstract reasoning, and also to test their frontal lobe, so that we can test their degree of measure their degree of executive functioning. It's very important to get these as a baseline when the patient comes in, because when you want to test them in the future, you can see you have some type of marker to assess their progress or during that period of time. So it's a pleasure for everyone. And again, if you're having any issues with ecstasy and you would like me to manage your case, I do a lot of inpatient work and get an assessment on my online clinic, and we can do your workup on your online clinic, come up with your treatment plan and medication, then have you admitted to the hospital of your choice. So contact my online clinic, and if you need help, we'll be able to help you. Thank you so much. Other than that, I'll see you guys later. Take care, guys. So let me go ahead and get started. This discussion is on the mesolimbic pathway. And specifically, we're going to talk about the effects of PCP and LSD. Let me just take you through some of our earlier discussions here. First, we here in our discussion on these pathways, remember we looked at this mesocortical pathway right here. And this mesocortical pathway, when it's injured, basically before puberty, it results in symptoms that consistent with autism, right? However, after puberty, when this network is damaged, we can see hyperactivity results in symptoms that are consistent with positive symptoms of schizophrenia, and hypoactivity seems to be associated with negative symptoms of schizophrenia. And we went through the receptors located on this nerve bundle. And this nerve bundle is primarily innervated by dopamine neurons. Also, remember, they have glutaminergic neurons on them, glutaminergic receptors on it. Remember, they also have, I believe, serotonin receptors on them and norepinephrine receptors on us also. Excessive glutaminergic activity can really excite this nerve bundle, and you'll see positive symptoms of schizophrenia. Later in our discussion, we moved our attention over to this other very important network, the mesolimbic pathway. Mesolimbic pathway, and this is sort of like the reward and learning pathway. And remember, this is the target for substances that are used in abuse, for substances that are abused. This is the primary target. Hyperactivity is associated with symptoms that people want that's associated with intoxication. And hypoactivity in this network, typically dopamine depletion and withdrawals. We went through cocaine and the impact that it has on this system, causes the release of presynaptic dopamine into the synaptic cleft, and results in increased transmission along these dopaminergic neurons, therefore making them hyperactive. And it comes from the vesicles that are stored presynaptically, and those vesicles dock and they release the dopamine into the synaptic cleft. But once all the presynaptic dopamine is gone, there's nothing else to push out into the synaptic cleft. And so now we have a situation such as withdrawals, and such the network is hypoactive. We also looked at the impact that ecstasy has on this pathway. Again, ecstasy, I keep getting the nomenclature, MNDA, the name of ecstasy, and it activates NMDA, which is a type of G protein, type of glutamate G protein. So ecstasy activates glutamate directly through the MNDA as its receptor, as a target. The problem with ecstasy is that the activation of the glutamate leads to overexcitation, and you risk the cell dying